Meeting open to the public. We're okay then, live? We're good, yeah? Okay, just to advise members that the committee meeting will be recorded and broadcast throughout Parliament buildings and online. And to advise members and those in the public gallery that they're welcome to use their mobile phones as long as they're in airplane mode and all devices are muted. They can connect to the Assembly Wi-Fi, password details are available on the gallery rules, and it's not permitted to take photographs or record any of the meeting. So number one on our agenda is apologies. I have apologies from Philip McGuigan, and I think we have Orlia and Linda online. Is anybody aware of any other apologies? Nope. Okay. Moving on to number two, chairperson's business, and to advise members that a number of members have attended an online meeting with Ladies with Letters on Tuesday evening, and I would like to thank the Ladies with Letters for taking time to meet with members in advance of the briefing later this afternoon. And just to inform members, I've been contacted by the Centre for Independent Living about an event they hope to hold next Tuesday in Stormont from 10 to half 1, and they would like the presence of one of the Health Committee members to be along for that. So if anybody's free, just to get in touch with us and I can put you in touch with them. So item number 3 then on our agenda is draft minutes. I refer members to the draft minutes of the meetings held on the 6th of November, page 5 of the main pack. Are members agreed or content to agree the minutes as drafted? Agreed. Yep. Okay. Matters arising. There are no matters arising currently, so we'll move on to our first briefing, which is an oral briefing on the Adult Protection Bill. And I'll refer members to papers on tab 5, page 17 of your main pack. And I would welcome the following representatives. We have Rosaline Kelly, Senior Nurse, Professional Practice of the Royal College of Nursing, and Dolores McCormick, Associate Director of Employment Relations, Member Services at the Royal College of Nursing, Mr. McFetridge, Lead for the Adult Safeguarding Belfast Trust, and Miss Patricia O'Brien, Chair of the Regional ASG Nurse Group from the Western Trust. Okay. All right. Where are you?
Thank you.
Okay, folks. Thank you very much for coming, and invite you just to your opening remarks then.
Go first. So, Chair and committee members, thank you for the opportunity to present oral evidence today on behalf of the Royal College of Nursing. We welcome the introduction of the Adult Protection Bill and appreciate the committee's engagement with stakeholders throughout its development. I am joined today by Rosaline Kelly, my colleague from the Royal College of Nursing, who is a senior nurse in professional practice in the college and who provided key evidence to our response. The RCN represents nurses, nursing assistants and nursing students across all health and social care settings in Northern Ireland. Our members are at the front line of care in hospitals, community settings, nursing homes and people's own homes, and are therefore often the first to identify adults at risk and the first to act when protection concerns arise. You've already received our written evidence, which I hope you find helpful. I don't propose to repeat this information now, but we are of course happy to respond to any of the issues we have identified in the response or themes highlighted today. In April 2021, the RCN responded to the Department of Health's consultation on legislative options for adult protection. Our submission reflected the views and experiences of our members, many of whom work directly with vulnerable adults across a range of settings. At that time, we expressed concern that the case for legislative change had not been made with sufficient clarity or conviction. We are pleased to note that many of the issues we have raised have since then been addressed in the current draft of the bill. Currently, we are the only part of the UK without legislation in this area, and we welcome the introduction of the Adult Protection Bill and the committee's scrutiny of it. We believe the bill marks an important step forward towards a clearer, more consistent and rights-based framework for adult safeguarding across Northern Ireland. While our written evidence sets out our clause-by-clause comments, this afternoon I want to highlight a few key issues about how the bill will work in practice. So firstly, the duty to report and to cooperate. It is important to remember that it is important to remember that there's already a professional responsibility for nurses to raise and escalate concerns about patient safety. It is a professional requirement and not an optional extra. And we strongly support this clause within the bill. However, it is vital that the duty is implemented in a way that supports rather than penalises those who speak up. It is crucial that staff feel empowered and protected when fulfilling these obligations. The success of this legislation will depend on its implementation and not just its intent. We have seen, for example, how the important provisions for independent mental capacity advocates under the 2016 Mental Capacity Act remain dormant almost 7 years later. We cannot afford a repeat of that experience. The advocacy role in this bill is essential to ensuring that adults at risk have a genuine voice in decisions affecting them, and arrangements to establish that service must commence as soon as the legislation is enacted. The bill will have practical implications across various settings, including the independent sector, where many adults at risk live. Our nursing home members have expressed broad support for the bill, but they also stress the need for clear guidance, consistent training and appropriate resources. The principles of autonomy, dignity and proportionality set out in Clause 1 are welcome, but they must be underpinned by realistic staffing levels and professional support if they are to be delivered in day-to-day care. Finally, we must not lose momentum. There is understandable concern about the lack of a clear timetable and the absence of detail on funding for implementation of the bill. The workforce will need adequate preparation and resourcing to put the bill's duties into effect. Without that, we risk creating expectations that cannot be met in practice. In conclusion, the RCN supports the overall purpose of the Adult Protection Bill and is broadly content with its current drafting. It has the potential to strengthen protections for adults at risk, improve interagency cooperation and enhance professional accountability. But to make a real difference, it must be implemented in a way that is timely, properly funded and achievable on a practical level for those delivering care on the ground. Central to achieving this is the development of the statutory guidance, a phase of the work the RCN is keen to see progressing. Thank you, and we look forward to answering your questions.
Thank you. Lois, will we take the other, any other presentations, any other opening remarks now, and then we'll have questions after?
Okay, thank you. So, good afternoon, folks. Thank you to the Chair and to the committee members for having us today. I am Joe McFetridge, as you've heard. I am the lead for adult safeguarding in the Belfast Trust Hospitals, a nursing role, and this is my colleague Patricia, and she is from the Western Trust. She's a specialist nurse within adult protection services there. It's exciting to be involved in this, to be able to come meet yourselves and to help to shape adult safeguarding in the future, since this is very much a key role of both of ours. We're attending today on behalf of the Regional Adult Safeguarding Nurse Network. So within each of the trusts there would be specialist nurses working solely within adult safeguarding, and we're here today to present that collective feedback. But we also want to highlight the involvement of wider nursing community, other nursing colleagues within adult safeguarding too, and the important roles that they also play. As detailed on our submission, again, like RCN, we'll not go into the bit by bit, our submission as such, but we do want to raise and protect the role of nursing within the adult safeguarding, really, and especially at this important time whenever the bill's being introduced. The need for nursing to be represented and to be very much a part of adult safeguarding was identified by NIASP at the time, and very much on an ongoing basis we can see that it is acknowledged that is essential. Where nurses don't oversee adult safeguarding investigations, as per the policy and procedures, it must be a social work to be a designated adult protection officer. Patricia and all her colleagues, they undertake the adult protection investigating officer role. So they will then look at the available evidence, they will fulfil that role, and there will be nurses within each of the health trusts that do fulfil that. So it's important that they're acknowledged in the bill. As well as that, building on that, all nurses have a role to play. NMC code very much clearly tells us that. Working in collaboration with NIPEC and with the PHA, we had produced the Safeguarding Adults Core Competency Framework for Nurses and Midwives tool. That was back in 2018. And that very much does set out the core knowledge, the skills, the competencies that nurses must have then at each level of, depend on their role, to fulfil for adult safeguarding. Very much for the bill in its current format, just by maybe perhaps focusing on the social work role, there maybe perhaps is a risk of the nurse role then being perhaps slightly eroded. So just that's why we want today just to, to highlight very much the importance of having nursing in it too. Things like the duty to, just other things we picked up on was maybe the duty to report. Is that a definitive list? There could be other people could be included in that too. But again, bringing it back to nurses, things like during the visits, during the interviews, nursing intervention in those would be essential, really. Especially during the interviews, nursing could also assess from a nursing standpoint, because we have the nursing training, we have the regular skills there. About the collecting of the records, so again, if a nurse is an investigating officer, they may well be going to wherever they may be, collecting them, examining the records as well. Very much just then to close as well, again, in keeping with what RCN have just said, very much during the scoping and the development of the associated procedures, just will there be cognition of the training needs of other professionals, i.e. nursing as well, and also the funding that's required to continue and build on the important role that nurses have. Thank you.
Thank you, Joe. And that's all the opening remarks? Yeah. Mm-hmm. Yep. Thank you. Thanks both of you for that. For this legislation to be successful, I know you touched on it there, Dolores, just about the guidance. I think it's clause 22 in the bill. What needs to be in that guidance for this legislation to work, in your view?
Yeah, so in our view, and that's a piece of this jigsaw that we are most keenly interested in as all our nursing colleagues. Mm-hmm. So within that guidance, so we have the bill or the act, and that very clearly lays out the statutory powers that will come with it. Mm-hmm. The piece for us is the amplification of that in terms of what that will look like on the ground for safeguarding vulnerable adults and indeed for the protections of staff. So the guidance must amplify some of the things that Joel has just articulated, how it will work in practice. The big thing for us is the capacity issues. We are already working in a healthcare environment with many deficits in our resources. Big thing would be the training. So I said there about the intent. We need more than that, than the actual bill. We need the intent on the ground. So it's about the training. It's about how that's delivered. That it listens to patients. That it listens to relatives, and that it listens to staff. And that will all. We are certainly hopeful or confident that will all be teased out in the next round when the statutory instruments are being designed and then the subsequent regulations.
Joe, anything to add to that? Or?
No.
In terms of reviewing the guidance, do you think there should be a time period when guidance should be reviewed? Have you any views on
that? In terms of reviewing, I think even keeping a review of the actual act, I think it has to be written in a way that it can be reviewed, because there's certain things that may need consideration as we go into it. So I think a review chair needs to be built into the system, even at this level, even before we get near the statutory instruments. And they definitely, if we look at the lessons from across the UK in terms of where there's similar legislation, like Scotland, they're, I don't know, many years later, they're still learning the lessons. It certainly hasn't been the panacea. It doesn't change the culture. So a review has to be built into the system.
Okay. What can professional bodies like yourselves bring to the development of these guidance?
Where, Joel?
I was going to say expertise, really. As people are working on the ground, as nurses that are actually involved in the day-to-day adult safeguarding practice, whether that be operational, whether it be strategic, like myself, we're doing it every day, all day, so we can tell, what are the issues, what's working well, what's not working well, and we can obviously then flag them up for, possible review.
Okay.
Could I add something?
Yep, certainly.
Chair? Thank you. I think a review, first of all, I've woken up this morning with no voice, so I apologise. You might have to listen very hard. But I think building in a proper review mechanism is really, really essential. If we look at the situation that we are in at the minute with the mental health order and the code of practice, it's a very, very outdated statutory piece of guidance that supports a very outdated piece of legislation. Now, there has been substantial work done on that just at the minute, and there's a consultation open on that at the minute about a revised code of practice. But if you look at that code of practice now, that is relevant to a piece of legislation from 1986. The language is outdated, the practices are outdated, you know, and there have been so many more agencies developed who all have a very specific role in terms of, you know, supporting people with mental ill health and implementation of that legislation. So having something formal set there to say, yes, it must be reviewed to bring it up to date, so that the most important thing is clarity. It's clarity about what is it each individual practitioner in each individual organisation is supposed to do, and when, and what are the limits of their, you know, of their role in this, and at what stage does it get handed over to another agency or to another practitioner or whatever that happens to be. And I think actually we can take lessons from how the mental health order code of practice has been revised to do that, and the work that is ongoing in terms of the right care, right person policy, in that I'm part of a working group that's looking at interagency working and how each of the different agencies interact together, specific memorandums of understanding, even the likes of the Northern Ireland Housing Executive as for powers of entry, and, you know, we're involving all of those people. So that's going to be a really comprehensive piece of work that sets out who does what and when, under what legal authority, and what their limitations are when you hand over. So something like that, clarity for me is absolutely essential.
Thank you very much. That's a lot of detail there. Thank you. I'm going to open it up for questions. So we've got Linda coming in. Linda?
Thank you very much, Chair, and thank you for the presentation. And we're going to definitely have more nurses in front of us giving presentations. Those are the briefest, most succinct, and easily understood presentations we've ever had. So thank you very much for that. Really, really appreciate it. I think that you're right about the review mechanism, and for me, Chair, I think that needs to actually be built into the legislation and not in the guidance. And I think that's what you're saying, that you would like to see it in the actual legislation itself. But I do think that is necessary, because guidance is only that, guidance. I think for a review to be absolutely certain, I know when we've previously done the domestic abuse bill, the review was built into the legislation, and I think that is invaluable. And I mean, we may want to tease out with officials whether we identify who would be responsible for that review, how it would be done, when it would be done, on what kind of a, you know, is it a rolling thing? I mean, you certainly would have to give a period of time. I don't think that you could say it should be done a year after it's put in place. That would not give the time to do it. So I think that is important. Just in terms of then, you've talked about the powers, you know, around the visits, interviews, records and removal orders, and they only name the social worker. So just from a nursing perspective, are there clauses that should explicitly, you haven't said this, so I'm assuming no, but I just want to be sure we're right, that you think should explicitly include or suitably trained healthcare professional, or you think that should be kept as social worker?
Yeah. So in our initial submission, very much a lot of our submissions were in relation to that. It was be accompanied by a nurse or suitably qualified healthcare professional, as in its current format. Yes, I mean, DABOs are social workers, so they would be the one that would be overseeing. They would be the ones that will be, you know, applying for those orders, say be removal, whatever it may be. But an IO, who could be a nurse, could be another profession, may well be going with them to assist with that too.
If I could just add, sorry, Linda, if I could just add to that as well. The bill as drafted is very social work orientated and social work heavy, and rightly so. It's the core functions for social workers. But I do think that, as Joel has said, there are very specific things where registered nurses with the relevant knowledge, experience and skills will be absolutely essential in assessing and evaluating, particularly if it's a healthcare issue that is the issue of concern, rather than a social care issue as the issue of concern.
And do you think it's sufficient then to have it in the guidance? Or do you think there should be something then changed within the legislation? Sorry, Chair.
I think it would be helpful to have it in the legislation and worded in such a way that, you know, there would be of benefit to the person who's at risk.
Yeah, no, I appreciate that. I'm really pleased to hear you talking about the right care, right person issue, because I'm on the policing board as well. So that is I suppose a pet one of mine, if I'm being honest about it. No, look, I think that's all I wanted to tease out with yourselves. I think just in terms of that, Chair, it might be useful if we were going to discuss that with officials, maybe if our CN or, you know, if a group of you wanted to sort of send us something specifically on that, what do you think that might look like? Or, you know, in terms of the wording, because the wording will be very important, you know, how it is worded in terms of, and nobody understands that better than you. I mean, we as MLAs will not understand that because you are the professionals. So we need to be sure that we get that right. And I think we just would need to have maybe a wee bit of tic-tacking and to and fro with RCN in relation to that. And, you know, it may well be something that the minister's prepared to, or the department officials are prepared to put into the legislation. We might not have to be looking at amendments or anything like that, but if we have the wording and we can say to officials, this is the wording that will work for the professionals.
Okay. Yeah. I mean, we'd be happy to do that and work along with the safeguarding nurses to try and get the right. Obviously, we'll put it in such a way that it might need to be changed to fit with legislative language, you know, but
no, look,
we can make a suggestion.
Work on that. Yeah, we can absolutely work on that. No, listen, thank you very much. And as I say again, brevity in your presentation is much appreciated, and allowing us the opportunity then to ask the questions. Thank you.
Thank you.
Thank you, Chair.
Thank you, Linda. Nuala?
Thank you very much for the presentation. I have a few questions. First of all, around the specialist nurse role. And I understand its kind of creation in this context was not so long ago. But do you think that the provisions in this bill kind of protect and provide enough for the continuation of that? I note in your submission you did raise some concerns around the continuation of the role, so I just wonder if you can kind of outline a little bit more of those concerns and what they actually are.
So I think it's really important that the nurse specialist in adult safeguarding is kind of included in the legislation. I currently work within a social services social work team. I'm the only nurse across the Western Health and Social Care Trust. My job is essential in order to look at records, give opinions about maybe care wasn't delivered appropriately in accordance with assessment and so on. That to me is a function as a nurse, and that is essential that we have the nurse specialists included in the legislation.
Is that for whenever it's the investigative side of the
investigation? Yes. Mm-hmm.
And then for the actual social worker, is the DAPO, should it always just be a social worker, or is this something that's ever been touched on before, that it's actually something that
we both
could be capable?
We do have a function as a social worker for our team in investigations, and also the nurse also has a function there. They're both not only beneficial but essential in order to be able to screen a referral that has come into our team.
I suppose just to say as well, prior to this policy and procedures, the previous ones, there were nurses were DAPOs as well.
Okay, yes.
It's
just, it is possible.
It is possible.
That's what I was. Okay. And there was another issue that I wanted to expand a bit on, that I don't have a great deal of knowledge on, and that was the Mental Capacity Act and how it's partially implemented. I think in what areas do you think that it's kind of the progress has slowed and we haven't seen its implementation. I knew in 2022, wasn't around whenever that act was being passed. So what do you think would actually need to be pushed forward to kind of enable this bill as well as just fully implementing the 2016 Act?
Yeah, there's certainly overlap. There seems to be overlap or interfaces between the part in this bill and the Mental Capacity Act. At this moment in time, like you said, yes, it is only partially implemented, primarily around deprivation of liberty. I suppose my big concern in around that is, and I know the department are doing work to look at what it looks like to implement the rest of the Mental Capacity Act, which is going to be a number of years away before any of that gets progressed. But the Mental Capacity Act is about safeguards. If we think about the Mental Health Order, it very much talks about powers. But when we are moving to the Mental Capacity Act, we're talking about safeguards. Safeguards for the person who lacks capacity to give consent for a particular situation, and safeguards for the person who needs to do something with, for or to that person who lacks capacity. One of the safeguards was an independent mental capacity advocate who had a key role when there was going to be a serious intervention. Deprivation of liberty is one of the most serious interventions that can happen under the terms of that Mental Capacity Act. You're taking away somebody's liberty. Now, I understand the explanation that was given at the time in 2019 when the deprivation of liberty safeguards were implemented. We just weren't in a position as a country or as an organisation or institutions to have the independent mental capacity advocate role available. But we're sitting here now, 6 years later, post the implementation of the deprivation of liberty safeguards, and that safeguard, that huge safeguard that was advocated as part of the Act, isn't there. I think we just need to be clear we talk about prosecution. In the Mental Capacity Act, there's already enacted parts of that which is about ill treatment. So where does that interface? Yeah. Do you identify the ill treatment first of all under the Mental Capacity Act, and then do you use the part of this bill to proceed prosecution or investigation? I think that just all needs where are those interfaces so that those using are acting, working underneath the parameters of this Act and within these legal frameworks know exactly what they're doing, so they're doing the right thing for the best outcome for the person who needs to be protected.
Thank you. That's actually very helpful. I think that's something that we probably want to explore further with this bill, something that I wasn't aware of until you had highlighted it there. And so do you, just finally, in order for the full implementation of this bill, which we know will take some time, do you think it's necessary to have the full implementation of the 2016 Act then, to have that advocate? I mean, I'm in my head, I'm thinking of scenarios where the advocate would have a role in this current bill.
Yeah, I think it's two different roles in the left. The independent mental capacity advocate is a very specific thing related to certain provisions in the Mental Capacity Act. This is going to be a different thing. So
their role will, in a sense, come to an end once it's reached investigation stage.
Potentially. But that's something I think needs to come out in the statutory guidance again as to what their specific role is, who these people are, how they act, and how they support a person who might be at risk.
Okay, thank you. And my final question was just that in relation to Clause 5 and the accompanied person that Linda previously brought up, why would it be so important for there to be the possibility to have, alongside a social worker, another qualified health professional on the visits by social worker?
Multidisciplinary approach, really. Each brings their own skill set, their own knowledge, their skills, their values. Nursing comes with their lens, social work come with theirs. So very much is about working on partnership, best outcome for the person.
I come in there and just on that. It's all about context. So you asked the question about the specialist nurse and the role of the specialist nurse. It's about, if we're looking at a neglect or a poor delivery of healthcare, as Joel says, the nursing lens, but sometimes if you don't have that nursing lens on a particular situation, social work may come at it from a different angle and things get blown up maybe when they need to be, or maybe not blown up and should have been. So it is really important to have that additional lens.
Okay. And that wouldn't have to be a specialist nurse that does that with the visits, because that's only in the. I'm just trying to make sure I know understand all the roles for the.
The specialist safeguarding nurse might say, let's just say it was wound care that was being badly managed. Well, the specialist nurse might say, I want my tissue viability nurse in here for a professional opinion. So it's all about a multidisciplinary approach.
Fine. Understand. Okay. Thank you very much.
Thank you, Nola. Alan?
Thank you very much, Chair. The evidence that we've taken so far from different agencies, everybody seems to be broadly agreed that CCTV is a desirable thing to have in these settings where there are vulnerable people. But everybody has their own concerns and have expressed that in their evidence. I note that you have referred to it in your written submission about your sort of broad attitude to it, but would you like to expand on how you feel about the use of CCTV?
I suppose the first thing I will say, Alan, is CCTV will not change culture.
No.
It will not change poor practice. And whilst speaking for the college, it's not that we would have any we wouldn't be absolutely opposed to it. We would be saying, number one, if our health service is in such a state that we need CCTV to make sure people are treated with dignity and respect, then where are we? That's my starting from it. So if CCTV, and I see that it's certainly in there in the bill, there would need to be a lot of work, a lot of consultation. It's very, very complex. But we just must remember that if you're living in a nursing home or a residential home, that is your home. And I don't know if I'd want CCTV watching me in my living room. It'll interface with human rights, touches on the deprivation of liberty, which Rosaline has just mentioned. So it is extremely complex. And if it were to be implemented, there would need to be really strict governance around it in terms of, I don't know, just where would you put the CCTV, who has access, all the data protection. So I'm not really answering your question, but we have a broad view on it, but our starting point was it will not fix poor culture.
Would you accept that you quite rightly say that it'd be a shame if our health services reached a point where we need Big Brother looking at everybody and everything, but would you also accept that in this day and age of way people will go legal over the smallest thing, that it's also there as protection for nursing staff and professionals working in these, they are just as vulnerable to accusations that are false or have no substance, and it does, so it's a two-way tool. Would
it is indeed, and we are accepting that in our EDs at this minute. We have got our pilot in the Antrim ED, and we are accepting it, and it has a place. I suppose slightly different lens in that it's someone's home. And it's, what is it? There is a tension there between the two, but it would need a lot of consultation, a lot of thinking, and a really, really tight governance around it. I don't know, Joel or Patricia, if you want to.
Just on behalf of our regional group, what I would say is, we do actively encourage the use of CCTV. It does need to be undertaken in an open and honest manner. Would need to be very robust governance arrangements around it. I completely agree with RCN. It's someone's home, so there would need to be consent there. It couldn't be a blanket approach. Very much person-centred. I am aware of the RCN have got their their guidance on RCN on CCTV, and if that's covertly done, so very much if there was going to be within an environment, it would need to be open, honest, maybe signs up letting people know policies, procedures in place. Yeah.
Thank you for that. Thank you.
Colin?
Thank you, Chair, and thank you for your presentation. It's given us lots of food for thought, and I suppose just a comment on one or two of the things so far would be, a bill can't be prescriptive by its nature, but then where we need to be really careful is that the intent of the bill is clear, so that whenever there are regulations that are drawn out from that or guidance that's drawn from that it's fairly obvious what needs to be in place, because if there is any ambiguity about it, it'll often be yourselves and those that you represent that are on the front line that then are caught in between various policies, guidelines and approaches, and then it's them that get the blame 5 years later, 10 years later, and so we do really need to be careful, and I think we've got the benefit of maybe examples of a number of cases over the last number of years that we really should be able to draw on that to make sure that we can support staff, because it's an absolute given that we support those that are in units or in homes, whatever, that's absolutely given, but also to support staff as well, to make sure that they take the practice decisions, that they're in the full knowledge of knowing exactly what it is that they've been asked to do. I suppose what could be tied to that, I'm wondering, like, £120 million over 5 years to start to implement some of this, like swathes of staff that are going to be relocated out of one element of work and into other elements of work. I mean, if you had, I don't want to put word in your mouth, but if you had concerns from that front, it would be really good to know, because I think we really need to make them obvious to the department that you can't come along with a really robust, detailed bill that changes the way that approaches are taken and then not back it up with the right resources in terms of staffing and finance, because again it will be your members that you represent that will be left doing the job of 2 people on the ground or looking for help and support from allied professions that are just depleted of staff. So is that a worry, and do you think is that something that we should definitely be articulating to the department, that they need to get that bit of the jigsaw puzzle right first before we move on to the implementation stage?
Yeah, it absolutely is a worry. So we have safeguarding policies and processes in place as we stand. We're not sitting here with nothing. We have policies and procedures there, and we have people, or my 2 colleagues sitting here, who work within safeguarding. So it's not a complete clean sweep. So the biggest issues for us is obviously there's funding issues, but it's about that someone somewhere takes a good look at what the statutory guidance, what it looks like, what the statutory guidance is requiring of us in terms of staff on the ground, and putting a costing to that. But what we don't want is are any of our members ending up, as you say, with 2 jobs. So we would be absolutely clear with the department, this bill can't hit the ground until that costing's been done. And at this minute in time, you know, we have staffing deficits in nursing and social work, huge gaps. People undertaking this work need to be experienced people. This is not these are not roles for people who are just new to healthcare. So that all needs to be built into the funding and the business cases around that.
Absolutely, totally agree. Just there needs to be proper funding, proper training, and proper guidance as well, so staff on the ground are very clear what's expected of them.
And what's the lay of the land at the minute then, just to finish, is there a fully funded resource service at the minute, or do you find that there's difficulties at the minute in terms of resourcing and funding for the current work that you have to do?
Difficulties with funding even at the minute, that would be the simple answer. You know, just increasing demand year on year, increasing referrals, more complex work. I'm sure Patricia would agree. Yeah.
And that's obviously impacted as well, I'm sure. With the ageing population, we're going to have more and more old people. We're going to have more and more homes for old people. We're going to have more and more people that need to be.
We have more and more vulnerable patients receiving care, and we have our members who are, and it's not all down to the health resource. There's the PSNI and the public prosecutions resource, but honestly, the delays, people sitting suspended for years as they go through safeguarding procedures. So there's quite a lot wrong at the minute that this bill will not fix, and it's a resource issue. And as Rosaline was saying, agencies talking to each other.
And just increasingly the need for us to get this right, as you realise this will be the bill that probably governs us as we're much older as well. So let's make sure we get this one right. So some sooner than others, and I refer to myself in that. Not looking at anyone now. Keep my eyes down. Pass it back to you, Chair. I'll get in big trouble.
Thank you, Colin, who had a big birthday recently.
That's why I'm getting this right.
Yes. Let's see. Thank you, Dan.
Well, isn't it great that
Over to you, Dan.
that I have followed Colin after that remark? Seriously, Colin has actually encapsulated the question that I wanted to ask you, and apologies. I took a tickly cough in my throat, so I had to go and get some mints, which I no longer actually seem to need. One of the things that I find difficult to figure out with the bill is how much it's going to cost to actually implement. And I don't think there's any sufficient costing in that. And I noticed in your opening remarks, Dolores, you referred to that. And then if there isn't sufficient funding, you lose momentum with implementation. And therefore, all the good work that the bill is intended to do gets a bit lost in the system. So, I mean, I just wanted to get your impressions of costings from what you've read and what I've read. I haven't been able to sufficiently work it out, but maybe that's just me. And secondly, the potential is, and I think the Minister has said this, that he'll implement the bill incrementally as he finds the money to do so. Surely there are huge difficulties with a bill that's implemented incrementally and not actually fully in place. So it was just those 2 points that I think, I think you're probably the first people to mention that, but I do think that is important that we consider that, because some other folk had mentioned to me the difficulty in the partial implementation of the Mental Capacity Act, and that one bit of it is done and the other bit of it needs to be done but isn't, and therefore has created a lot of harm and confusion as well. So maybe just a comment around that and the funding issue. And I must say I agree with you that the loss of momentum, I mean, this bill is partly in response to a very great harm at Muckamore. So therefore, we want, on behalf of all of those people and for the rest of us in future years to come, to make sure that it is done correctly or to the best that we can do at this time.
I mean, I can talk about the partial. I can maybe talk about the partial implementation bit of it. But I understand the concerns. I understand the explanation that was given at the time for the partial implementation of the Mental Capacity Act, and it was primarily about human rights issues and people not being deprived of their liberty, and there was no legal framework around that, and that was for that person and people detaining them. But we have run into difficulties because now we need to understand, well, actually there's no authority within that to provide any treatment to anybody under that Mental Capacity Act, so the person still can't give consent to say, yes, I would like you to help me wash, dress, give me my medication, undertake that intervention. The best interest, the statutory element of the Mental Capacity Act in terms of best interest hasn't yet been implemented, so there's no protection from liability.
Because that actually was an issue that came up with a case that I was actually dealing with. So you have mental capacity in terms of finances, but not in terms of health and well-being.
Yeah. Okay, so that has been difficult. Now I do know the department are working on a plan to, what does that look like in the future? What will it cost? What are the resources we need for that? That is quite a wee bit away. They are talking about implementing another piece of the Mental Capacity Act, Section 12, which is under acts of restraint, which will help with some of the challenges that have been encountered, because although there may be an authorised deprivation of liberty for a person, if you need to actually take them to a place, each of the agency doesn't know what their authority is to do that, because there's that part of the Act hasn't yet been implemented. So I think there's little pieces of the Act that are popping up in places, thinking that would be really helpful actually if that was part of it. So whilst I understand the explanation for that partial implementation in 2019, it has not come without its challenges, and the initial plan was to implement it all at the one time. I had read in the Hansard report of the departmental representatives being here that they weren't actually in favour of partial implementation, and we would be supportive of that in terms of this bill. In terms of the funding, I really can't answer that question at all. I really can't.
Okay, Dan, or?
Yeah, no, that's great, thank you. I just think that that's quite important, that we don't have an act that's good law but can't be implemented.
Absolutely.
It's very confusing for staff at the minute because they're using the mental health order in certain circumstances, sometimes they then have to transfer to the Mental Capacity Act. The Mental Capacity Act doesn't apply to under 16s. The mental health order, it's just a really murky field for people working under that legislation. So that again takes me back to the absolute clarity that's going to be required in the statutory guidance, because that's where staff are going to go. They're going to go to the guidance and they're going to say, I need to do 1, 2, 3, 4, 5. That's the order I do it in. Therefore, that helps me in my practice. They're not going to be reading that legislation every day, So that's why I'm saying the clarity in the statutory guidance is going to be absolutely vital. It's going to be crucial.
Yes, thank you.
Alan?
Thanks, Chair. Look, exactly similar thoughts as Diane and Colin when I was reading through the report, and there was a line, and I think it's probably the best line that I've read so far in the limited presentations that we have had: fragmented implementation and an absence of appropriate funding. I think that sums it up. I think that's a fear and frustration that we all have in this room. And if we're really honest with ourselves, we all know how this will develop. In 2 years' time, we'll see a review of the very limited implementation that has been done so far, and there'll be a further review. And people in this room, any limited area that they've left, they'll be pulling it out and fed up yet again with a department that seems to put these strategies in place and these bills in place, but yet they're half-heartedly done. And some will say through no fault of their own, and it is the environment and the fiscal environment that we're having to work within. And I suppose that was the question, and I suppose you've answered it as effectively, do you believe that the bill, for it to be fully effective and to do it justice, that it needs to be fully funded rather than the fits and starts, that we all know how this is going to play out? We know it.
Can I just add that as well? This is really, really important for people.
Absolutely.
Really, really important, and especially people caught up in the Dunmurry Manor situation and the Muckamore Abbey situation.
Exactly.
This is so, so important to get right for them. And, those people fight every day to get what they need for their relatives. So full implementation, in my particular view, would be the way to go in terms of trying to rebuild those relationships with people.
And just on the other issue that I wanted to just touch upon, do you believe your teams or the wider nursing cohort that they have the training and capacity to meet the bill's obligations currently, and what are those gaps?
Well, before I let these guys talk, I absolutely think nurses have the knowledge, skills, expertise, experience to do that. It does come, with experience, and the more experience you get, and the support behind you of the law, the guidance, the training, etc., are really, really important. I think what's going to be really important with this bill is allowing professionals to have that professional curiosity and to ask questions of a situation. The bill itself will be black and white, that's what law is, but in practice they need to also be able to develop the skill of professional curiosity, which I believe these specialist teams over here have. Absolutely they do.
Very much nurses working within adult safeguarding, I do believe, do have the skills, the knowledge, very well placed. With the bill coming in, no additional, not powers for nurses, but the changes, there may well be training required just in relation to that, but they are well placed. Back to the implementation of the bill, absolutely agree. The best case scenario would be a robust bill coming out in one go, enacted in one time, that really sets out the ethos of what's expected, alongside that with really good guidance for staff. But again, I'd heard someone say that was being considered maybe almost like a live document, like the Safeguarding Board for Children's. So you would go on, and the latest version's always online. So if there is changes, it's there, as opposed to something that's maybe published and then reviewed 2, 3 years, whatever later. If there's a significant something happens, it can be very much reviewed as and when too.
Could I ask just a very direct question? Do you believe that the bill is destined for failure without the appropriate funding?
Will be extremely difficult to do anything. I think staffing within adult safeguarding, I know the trusts are coming in obviously on behalf of themselves, but to put that workload onto an existing very stretched workforce would not be good. I suppose that's the easiest way to.
No pressure department then.
Enough on you.
Stanley?
Okay. Thank you very much
Can I
for
just ask
Yep,
one
certainly.
very
Go on
quick
ahead.
question?
Yep.
I take on board all the concerns about the fragmented implementation, maybe not satisfactory, and that's something that anybody in the room here is keen to see happen. But would you accept that fragmented implementation is better than no implementation? Would you rather that a department would say, right, we're putting this in cold storage until a point where we can fully implement it, and when we have the full funding to do it, would you feel that was a more satisfactory approach than the fragmented implementation?
I feel like it's a trick question because obviously what we want to say is we need this bill will fully, and like Joel has said, properly resourced, it's implemented in full. I think the lessons we have learnt from partial implementation of the Mental Capacity Act will show you that one bit doesn't work without the other. So it makes absolutely no sense to me in terms of this bill to partially implement, because it's going to limit what a person can do. Somebody who's given a power under this, or the authority to act under this bill, will only be able to go so far, and then that's going to be totally challenging and very unsatisfactory. So I don't think any of those options are really what we would be wanting to see. We want to see full implementation.
Would you prefer then to call on the department to put the legislation into cold storage until a point when they were able to fully finance it?
I think we'd like to see an implementation plan that's properly funded, and that as a matter of priority.
Even if that meant stopping the process at the moment because they don't have the finance to do it?
I don't think they need to stop the process, because this is not going to happen overnight. It's not going to be 1st of April 2026 that this bill and everything's, all bells and whistles. It is going to be a process of implementation, because we need to have the workforce, we need to have the guidance, we need to have the policy procedures, we need to have the robust training, we need to have all of that set up first before we get to a point where this, when it becomes an act, is actually fully operational at the optimum level. So I don't think it would be a matter of saying, right, well, we're just going to stop and restart it again in 2, 3, 4 years' time. There's a lot of groundwork could kind of be happening that could potentially, make progress whilst we're waiting on full implementation.
Okay.
I suppose just to add, it is so important too. There really is the need for it. So, it wouldn't be appropriate to put it in cold storage for many years, and not because of the reasons we've already outlined.
Yeah. Thank you.
Okay, guys. And thank you very much for your presentations and your answers today. It's been incredibly useful, and particularly to hear from professionals who are working day to day in this area. So thank you.
Thank you.
Thank you very much.
Okay, folks. We're going to move on to our next briefing. Item number 6 on your agenda is the oral briefing from our Independent Autism Reviewer, Emma Cubitt. So I'm going to refer you to your papers on tab 6, page 34 of the main pack.
Saying all dance and strategy doesn't fund it.
Autism AP?
I didn't go ages ago, I think.
Yeah.
I didn't. I hear
It's
something
in there the other day, and it was just How you doing? Hello.
away.
Yes. No.
Sorry for the clatter. Excuse me. It's been away.
Hello, Emma. How are you?
Very good, thank you, Vice Chair. Yes, thank you.
Thanks very much for coming today, and I'll just invite you to make your opening remarks.
Yeah, well, first of all, thank you very much for having me here today. And additionally, I just want to also thank the members who have engaged with me so proactively across the Health Committee and the manner in which you've done so. I always find my interactions have been really, really useful and helpful. I also wanted just to put on record, I suppose, my thanks to all the professionals and individuals across the community voluntary sector that I meet. I have had some of late some very positive interactions with professionals, really, really insightful, really, really helpful. I suppose I also want to acknowledge the autistic people and their families who do engage with me regularly. They reach out, share their insights with me, some of which are very intimate and distressing, and they're very personal stories. It's the most credible evidence base that I have. It's from those individuals that choose to share their experiences with me, and it's those experiences then that anchor the work that I do. So I'll give you an overview of what I think is happening right now and where we are. So on the ground, I think you'll all know families are very, very tired. They're navigating systems that were never designed for them in mind, or with them in mind. We know about the long waits for assessment. The respite has not yet stabilised, and we have unreliable and inconsistent post-19 pathways. So these are not anomalies, these are the everyday signals of the strain inside a system that is attempting to transform while still delivering. It's a system under pressure, but it's not necessarily a failing system, but it is telling us clearly where the limits are. So I want to speak very briefly about my role and my remit and some of the constraints and challenges I face. I'll only touch on that briefly, and I would really welcome members' questions on that. So I have the statutory duties. I'm a critical friend across the system, across all departments. It's a broad and complex role with scrutiny, monitoring and advice. And I will answer questions if members want in relation specifically to the autism strategy. I don't manage or direct services or support, but my role is to give yourselves and the whole system an accurate picture of what's happening, where gaps exist and where opportunities for improvement are or may be missed. And that picture spans across every department. And we know autistic people are in our schools, hospitals, workplaces, courts, housing systems, cultural spaces and communities. So every department has a role and every department has a responsibility. And that would be a statutory and moral responsibility. In terms of my office, it's lean and very lightly resourced, but my statutory functions are not. If the Assembly intends my oversight mechanism to have an impact, it must be supported with resources and the stability that I need to perform my role fully. So in terms of the system and the system readiness that we're seeing now, in terms of system reform, scrutiny has the greatest impact where the systems understand the expectations that they're being held to. In Northern Ireland, unfortunately, we still have cultural attitude and knowledge gaps about autism, about identity, rights and universal and diverse needs of the autistic population. And these gaps are really creating a massive drag within and across all our systems. They make it harder for reform to take hold and harder for scrutiny to land. And that is why I've sequenced my work deliberately. Aside from the capacity issue, I want to make sure that we have clear shared expectations. And high-performing, learning-orientated systems do that. They build understanding, they align standards, and only then can you accelerate accountability. And that's what protects autistic people and also protects our system. So we are moving in that direction, and it is encouraging. But from the wider view that I take when I look at and spend time with autistic people and lived experience, and then I stand back and look at the system as a whole, we are in a transformation moment. I mean, I know you have much more experience across the years in terms of transformation and reform, and perhaps we're always in a space of transformation and reform. But in terms of autism specifically, with increased awareness, we now and expectedly see a rise in diagnosis and the identification of need. So we have been essentially through a proof-seeking phase where the system has sought validation of who's out there in our autistic population and what the needs are. But that system has always framed need after diagnosis. So the next stage is, I think, where we need to have needs accepted and inclusivity without the constant reliance on formal diagnosis and assessment and reports. So we're in that reform and transformation across particularly health and education, and if it is allowed in the space of autism and the wider population, and if it can bed in, I think we can recentre where inclusion is normalised and assessment and diagnosis will no longer become gatekeeping tools or a drain on the resources of those who can actually offer help and support. So my view, this is my expert view on this, is that I think we're seeing the signs consistently across systems that we have reached a tipping point. There's a rising number of autistic people seeking support, a rising number of children with statements of educational needs, unprecedented assessment waiting lists, variation in practice across trusts and departments, and an operational strain that is visible at every front door. And I need to be clear, because this is not about too much autism in society or too much diagnosis. It's absolutely not that. What I'm saying is this is unmet need, and what it looks like in a system that's transitioning from reactive practice to rights-based and inclusive design. So at moments like this, systems can do one of two things. They can double down defensively, tightening thresholds and inadvertently widening inequalities, or they can lean into transformation and redesign the processes, address workforce capacity, and critically embrace cultural change, and then strengthen accountability. And that's what I really want to see, particularly in relation to cultural change. We know the Minister's position in relation to Shift Left and his reset agenda, and there is an emphasis within that on learning systems, systems that learn and improve through that learning. And we can see that there's a change across trusts as well in the movement of better cultural openness. But all of this requires consistency and, very importantly, cross-departmental ownership. So if reform and cultural change are under-resourced, and where the economic dividend is not embraced across all parts of government, and where process stalls are overshadowed by distracting narratives or politics that we often see, it will snap back and retrench itself. And we will see that institutional defensiveness and further pressure on families. So in my view, we need clear leadership that decides which direction the system will move in for our autistic population. I met yesterday with the heads of service of trusts, and I can speak to this if members have questions around the waiting list issue. One of my gravest concerns in relation to the length of the waiting list is the harm that occurs to people while they're waiting. It's a really grave concern, and I actually think we're making people physically, mentally unwell, and we're taking parents out of work. I see that as a massive issue. I will also speak further, if members wish, in relation to respite and short breaks. I think in terms of the spend, the funding, this committee has done an excellent job in terms of getting feedback on that. I'm aware of some of the updates from the department, but they're not released to me from the department in full, which obviously it is frustrating. But in terms broadly of respite, I suppose what I want to see really now is that it's protected, it's sustainable across changing political and financial mandates, and that we really see the quality that's coming through, that our parents and families feeling a reduction in stress, or is it improving their lives? And I think that's where my interest really lies. And in terms of learning from respite and short breaks, I would like that crystallised. I would like that learning documented and reported on. I fear that we see the same problems in different parts, particularly with post-19 provision. We're missing that cross-government ownership and infrastructure, and I think that post-19 and the challenges there quite closely reflect respite and short breaks, and certainly I don't want to see families who continue to struggle for post-19 provision, who end up in the depth of distress and despair that many of those families seek. And obviously there's a crossover between the families I'm talking about in post-19 and respite. Across all the areas of work that I've done, there are same patterns emerge time and time again. Autistic people are meeting systems that haven't embedded that inclusive design or neuroaffirming practice. These are not small gaps, but they are cultural and relational, and these gaps, if addressed, would really be the foundation of change, and I think they are, or at least should be, fixable. So my scrutiny is not judgment or criticism. It has to add value. It's a statutory safeguard. It's a mechanism for learning and improvement, and it does have a place. I consider, particularly in this time of reset and transformation. But to be clear, for scrutiny to function as it's intended, it has to be protected, it has to be stable, and it has to be properly resourced, and it has to be recognised as a cross-government responsibility. And without any of those things, the Autism Act will remain progressive on paper but under-delivered in practice. And to be very clear, I am absolutely dedicated and motivated in spite of what the constraints in my capacity may be as the Autism Reviewer. But I want to do more, and I want to be enabled to fulfil my statutory purpose and the intention of the legislation and the intention of the Assembly. At the time the legislation, both pieces of the legislation went through. So that's essentially a very quick brush of where I've been and where I see things are. So I'd be really welcome your questions.
Thank you, Emma. And my engagement with you, I'm very, very clear that you're incredibly dedicated to this role, and certainly you've been very, very helpful to cases that we've discussed. So
thank you.
Just want to put that on the record. You described your office as lean there, and that you need resources and stability in order to carry out the role. Do you feel that you have sufficient resources in order to meet the aims of this role?
No. That's a simple answer. In terms when I say lean office, there's me and my head of office who's sitting behind me, who's incredibly diligent and dedicated, and I'm very, very grateful to Alan. But no is the simple answer to that. Other than my time is capped, so there's only it's been difficult, very difficult, and I am capped. And I find that very restrictive in terms of it's a daily rate, and I now have to manage, given the demand of the role, I have to manage that now between now and the end of the financial year. There's an interim measure in place, but it's been interim since I took up the appointment. There's a small pot of money that's been available, but with only 5 months. And as it's available just now, it's a very small pot and with only 5 months. In one sense, whilst I'm very grateful, it creates almost more pressure on two people to try and do something meaningful with that in a very short period of time. So aside from expenses, a daily rate, travel, that's it. So when I say lean, that's it.
The extent of your office is yourself and Alan?
We did have part-time administrative support from the department, but we lost that at the end of August. So it's essentially all hands on deck. I will always intend that the office, for as long as I am here, that it will be a lean value for money office, but there's lean and there's this.
What would you need in terms of sufficient resources in order to carry out?
I have identified that need to the department on more than one occasion, that they're well aware of what I need. And it's probably not terribly helpful to get into the specifics of that now. But I have also identified clearly, both to the Minister and to the department, the risk in terms of, this is a statutory role with statutory functions. And in terms of there's no contingency, and I am one person essentially, and people do burn out. So
huge pressure at the minute, not enough resources.
Yeah, in a nutshell. Yeah.
The department and the Minister are both aware, and you have spoken to them about what you need.
Yeah, I have.
Okay, thank you. One of the things you mentioned there quite distressingly was that you had noticed the well-being, mental health and physical well-being of people who were waiting on waiting lists for assessment deteriorating. Could you talk a bit more about that?
Yeah, so what I can say is I'm very aware, having engaged with families and professionals know this as well, that waiting period is very distressing for a number of reasons. But just ahead of my meeting yesterday, incidentally, I did a little bit of early kind of exploratory research around the impact of being on a waiting list for a long time. My findings, albeit early, were very stark. we're talking sort of that psychological and well-being, sense of belonging, identity. Particularly, I think when a younger child, it's really difficult for families. In adolescence, we're looking to self-esteem and identity. But I think to be really clear around the weighting, I can't just give you an exact sort of scientific or data approach on that, but the harm in weighting for an autism assessment is not quite the same as it would be on another weighting list, because once you get your autism assessment, you may not get support. So it can be a very traumatic run-up to an assessment, and thereafter. Quite interestingly, yesterday, when I spoke to the service leads across all of the trusts, we have really skilled professionals, consultants, and more who are undertaking very robust assessments for autism, anything from 7 to 50 hours. But essentially, they look at these individuals and they see the need and the need for support, and their time is essentially in that robust assessment process. Now, diagnosis, particularly for autism, is incredibly valuable, and I really support diagnosis. It can be life-changing for some people. But when you translate the time spent on that robust process, that could be translated into hours of support, it's quite phenomenal. And I should also say, Deputy Chair, that there is innovation within the area. We talked about what are the options. I'll not speak to what options they discussed specifically, but there are pilots that are going on, and the sense that I get from the Trust is we need a radical approach and a review of that space. And I don't think that just tackling waiting lists with money is going to impact the problem. It's not. Autistic assessment waiting lists are not the waiting lists that can be addressed in the same way as some others.
Thank you for that, and certainly it's something, as an MLA, my office hears a lot of, and I'm sure it's probably very similar for other MLAs as well, that we do get a lot of calls for 3-year waits for children and up to 7 years for adults, which is a huge portion of somebody's life.
Absolutely, yeah, and that for some children it's a huge part of their whole childhood. And I know I can speak from experience for parents and families of young children, it's incredibly isolating, and I'm really alarmed by the amount of families I speak to who have had to give up their jobs or reduce their hours. But we have people who work for our health and social care system who are parents of children who have to give up their work. So there's always a dividend, investment in one area will pay off in another. Just need someone with enough insight and courage to take those leaps of faith sometimes, that when you invest here, you may not see it in your department in your time, but it will pay off.
Thank you. Diane?
Yes, thank you for the presentation, Emma. A couple of things that I am intensely interested in, because they refer to constituency cases that I do and so on. So the Health Minister allocated 13 additional million for respite this time last year, I think it was. So I just want to know, have you had any communication with him or with the department on this? Do you understand how the money has been spent? How many additional hours of respite, as in overnight respite as opposed to daytime respite? I accept that both are important, but I suppose in case of the run-up to this allocation of 13 million, we kind of assumed that it was going to go for overnight respite and so on. I did ask this question of him in the chamber. He advised me to write to him, which of course I have done, but any light that you can shed on that would be really useful.
I can give you quite a brief answer, because no, I think that I should be seeing the same updates that yourself see. I see some, but some of the information is held back from me. In terms of the oversight board, there has been a verbal agreement that what goes before that board, which I understand was established in May, would be shared with me. I don't know who's on it. I don't know what they're doing, and I've had no updates from them. So I know less than you know.
So the question then is, how can you fulfil your statutory duty under the Act if you're not given the information that you need?
I can't, I think, is a simple answer to that. And anybody who has spent time engaging with me will know that I want to be robust, but I also want to make a difference in people's lives. We're talking of quality of life. It's not just about layering on services or changing models and frameworks. And I do find it continually frustrating that families and carers who are looking after those with the most complex needs have the most complex systems to navigate.
Yes.
I'm in this role just over a year, and it has been quite health and education heavy, and I am still struggling to get my head around it. And what I see is continually parents want to parent their children and their loved ones. They want to love them and have time with them. They become all sorts of other things: advocates, financial ambassadors and advocates and therapists. And, deep down, as parents, we all want to parent our children and we want the system to support us.
So I just want to go back, because I do think this is actually important for you and for us. So the evaluation of a particular initiative, which is very good, and finding £13 million additional to actually put into this is useful and good and the right thing to do. But if you have no additional information, no communication, then your overview role is more difficult. Have I got that right? Because I do think that it's something maybe the committee might want to actually take up, and we'll discuss that afterwards.
I can give you another example. So we have the Learning Disability Service model, which is out for consultation. And when I sat down to look at it, in my mind, I'm always thinking about autistic people throughout the course of their whole lives and how they travel through life and through systems. So when I went then to look for the Children with Disabilities framework to see how those two sit together, and quite often I do try to lay things along as best I can, a continuum of care, to see if we have seamless transitions. And I can't find that framework, and I don't think there was any consultation in relation to it. So I suppose there may be an argument in relation to some of these things, well, you don't ask, but the department know the limits of my resources, and I need to have proactive engagement. I do have it elsewhere. For example, in education, I have very proactive engagement, some elements of SPPG, yes, and those have been incredibly positive and useful for us and them. So you probably get the sense of the level of my frustration.
Well, I think we're all frustrated, and I accept that everybody has a difficult job to do in the department. I completely accept that. I accept that budgets are stretched, but where we don't have a line of communication, you can't fulfil your role, and therefore you can't disseminate the information about how you think the department is performing, which is part of what you should be doing. So I kind of think that is an important gap that maybe we should take up and have a look at and see what we can do. Can I ask you just, you said you talked to the heads of service of the trusts, and I had asked a question around the kind of the discrepancies in the trusts about the number of adults that were either receiving confirmed diagnosis or were waiting on a waiting list for assessment. And there seems, as with all of these things throughout almost all of healthcare in Northern Ireland, there seems to be a really big gap in trusts who do this and trusts who just do the minimum. So for example, the number of people waiting in the Belfast Trust is 662 adults. And you said a diagnosis is life-changing and almost life-affirming for people, and they start to understand what's happening. But in the Northern Trust, that waiting list is 1,647. These are just off a question that I asked. And so it's really, like, there's very, southeastern 973, southern 487. Any explanation why there's such a huge variation in those waiting? And there's also a huge variation in services towards adults with autism, or potentially adults, well, who are at least somewhere in that neurodivergent sort of landscape.
I can't make head nor tail of it either, Diane. So unfortunately, I can't help. It's an area I'm trying to get my head around. In general, the disparity between trusts is a concern. What I do, and this is probably where we'd need to have a really open conversation around the waitlist for assessment, is that there will be people who, and I suppose, I should say, we're moving into a space now across education and health where early intervention and support shouldn't require diagnosis.
Yes.
That needs to be cross-departmental. That needs to be broadly understood and actioned, and including, I'm talking about a Department for Communities, etc., is that you're not required. We have created a system where we require those diagnoses. For adults in particular, as I said, it can be life-changing. But some of those individuals then don't necessarily need to go on and access services. Some do, and they should be able to do that, but others don't. Others, the affirmation and validation of understanding themselves better is so incredibly valuable in itself. But I suppose that goes back to the harm issue. When you look at the value and you look how it changes people's lives, I can't imagine the harm that it does while you're sitting there waiting. I know of a number of autistic adults who have received a diagnosis and have been able to unpick what they consider to be a mental health journey and experience, and actually it's not, it's burnout, and they make their own adjustments. And I think that you cannot put a price on giving people that opportunity, but also, and I suppose it's something that sort of irritates me a bit, is we need to understand that autistic people have human needs like the rest of us, and sometimes you can be placed on a waiting list for an autism assessment and have a range of other needs that can be met elsewhere in the system, even while you wait. And we need to understand that, it's not good practice when people come into services for help and support and you're told it's your autism, when in fact you may have something else that can be treated elsewhere within health and social care.
Yes, I think that's very, very valid. I suppose my last question around this, and I'm kind of, despite a large waiting list, for example, the Southern Health and Social Care Trust in 2022 only completed 7 adult autism assessments, 23, 18 and 24, 14, despite a huge long waiting list into hundreds. And that is really failing people. And those are the kind of things that I kind of think that we need to be able to highlight in order to judge the services we need, and as opposed to the services people are getting.
I probably should sort of return back to a point earlier, which I'll probably come back to quite a lot. That is of grave concern to me, and I haven't had the capacity to explore that in any detail. Should I have greater capacity and resourcing, I could certainly, that would be an issue that would be top of my list.
Thank you, Chair. Thank you.
Hello.
Thank you, Emma, very much for your presentation. Autism is something that we have focused on a number of times in this committee, and you mentioned the committee's work in the respite issue. It is something that it is very emotive in terms of people at a crisis point and needing that intervention. But it also seems that we're failing people even before we reach the crisis point now. And one example is that the waiting list that we've all just spoken about, it seems that diagnosis has sometimes become like a gatekeeper for other waiting lists, which is deeply frustrating. And there are many organisations out there who do support parents who have not gotten official diagnosis, but there are some who are actually really constricted in what they can offer until you get a diagnosis as well. So it's almost like a lose-lose situation. You get your child through it if it's your child after waiting for years, and then you have to wait for either a statement and process in school to get your support in school, and then you have to wait for any external advice and support. And I wrote to the Minister about the early pathway scheme that was first talked about in 2021 with the establishment of the framework, the emotional health and wellbeing framework. Yes, and it was the coordinator was first commissioned years ago. It was talked about then that this early pathway, but I mean there was no response towards what actually has happened or taken place between 2021 and 2025 that will actually allow earlier intervention, so that you don't actually have to be diagnosed, that you can get the help. So in your role, have you identified areas of progress that are doing well that can be scaled up since this new project lead and our emotional health and wellbeing framework kind of was established?
So I'll tell you about something I found quite interesting is the cooperation and working together. COT launched a project called the Easy Project with Peace Plus money, and it's mainly in the border regions, and that really will bring early intervention into a real reality for many families, I hope, and they're responding to need and delivering support locally. And I spoke at that, and I will continue to liaise quite closely with the project board in relation to this particular project, because if done right and done well, and there was a significant amount of confidence and aspiration within the room, it could really be the framework for how we operate across the whole of the North. And this doesn't take away, and I have emphasised to trusts and to SPPG in terms of the framework, the emotional health and wellbeing framework, that they need to get the narrative really clear. This is not about taking away the opportunity for a diagnosis. It's delivering support that you need when you need it at the very earliest opportunity. And what we really want to see from early intervention is that families and children and young people are support is scaffolded around them, and as you know, as the support kind of beds in, you can piece by piece remove that, but you can also scaffold it back up again. Because autistic needs fluctuate over time, depending where you are and what you're experiencing in life. So my hope is, and I would encourage you to keep an eye on this project, which could potentially be, and I would really hope that through what little I can do to support that to become a really strong piece of evidence for early intervention. The emotional health and wellbeing framework, they're still working on the consultation responses, but the whole point of that is that you will not need a diagnosis to get help, and that is reflected within education. Now, I think there would need to be a very clear messaging piece around that, how that looks and how it works in practice. I don't know, but it really is it should be a person-centred approach. And certainly one of the things you'd mentioned there in people's experiences is that being bounced around. And sometimes when you're on the wait list for assessment for autism, you can get bounced between, for example, CAMS and the ASD service back and forth. I've been there, I know exactly what that is like, and it is very frustrating. There can also be that diagnostic overshadowing where you seek medical advice or support, and that's autism. Again, I've had experience of that as well. Autistic people have shared needs with the rest of the population. So in terms of the emotional health and wellbeing framework, I'm certainly working really closely with SPPG in relation to that, and we talked a lot about that yesterday. One of the barriers to that is resourcing. If our psychologists and people who work within that area are tied up in hours and hours and hours and hours of assessments, how then can they provide the support in early intervention? Now, there is definitely some good work going on, but it's only through hard work and creativity that people are making, you know, changes within people's lives. But there's just simply the balance of, you know, the assessment and all that's been taken up there.
I think we will approach a needs-based and a child approach. I'm talking specifically about under 18 approach to our healthcare when it comes to neurodiverse issues, but also education. You know, what some of the things we see in education, especially with children neurodiversity, is that they're not fitting into the school's approach to learning,
Yep.
but actually the child's approach to learning and even the support for family life and healthcare needs to be needs-based. Do you think that we have a long time before we get there, or do we actually have enough projects, enough tools that can be rolled out on a regional basis and to enable that?
Yeah, there's so much going on. There's absolutely no excuse for that to happen. No person, whether it be a child or a young person, should have to fit into a system. And the evidence base and the amount of easily accessible material out there to upskill people as a starter is, you know, it's there. We know what we need to do. Interestingly, there's work across a number of countries where they, and again, this is where I often talk about flipping the narrative. So we spend an awful lot of time looking at children's behaviours and the problems that they cause for the adults, but actually we need to start asking the question, we need to look at the environment, and a number of countries have asked the questions around school climate and environment as opposed to looking to address children's behaviour. It's, again, if I had capacity, I would be able to provide sort of a report on that, because it's really, really interesting. But I think at the bottom of it all, we can't afford not to. I see particularly our autistic population, and I mean that in the broadest sense, in terms of autistic people with co-occurring conditions, including learning disability, whether that be moderate or profound, those who are non-speaking, that there are untapped potential. And unfortunately, the further I get into this job, it's really heartbreaking the harm that I see is being done to really good people in Northern Ireland. It's dreadful.
No, I agree. Like, I see it in my kid every day, who, as soon as he walks through the school gates, his soul leaves his body. And it's really sad, because he has to fit into the system rather than the system work for him. But we shouldn't have a society where children have to conform to absolutely everything that is expected of them, but actually should be able to be educated and learn and grow and access healthcare and support.
Yeah.
I mean, we see it in our offices, families that have broken down, asking help with social services. One family in particular, who then adults were removed from the family rather than actually putting support in there because they didn't have the capacity to offer them support. It's really sad that we have reached that crisis point.
We also have to remember as well that we have autistic teachers, we have autistic principals. I met an autistic principal not so long ago. We have autistic lawyers and doctors, and I always try to say this, and I mean it really respectfully, but autistic people really are everywhere. They are, you know, the assembly.
Sure, yeah.
Yes.
Sure.
But the issue is, I suppose, that, you know, this is not just about one small group of individuals. This is not about. It's not just about children. It's not about a very small number of adults. And really interesting. And I'm going off tangent here, but there's actually emerging research in terms of our older population. So people presenting to dementia clinics who have suspected dementia. And it's actually as they're autistic and as their support needs, there's a support framework falls away, maybe the loss of their loved ones falls away, their difficulties come more to the fore. But I can never emphasise enough exactly the point you're making around people fitting into a system not built for them. But we're not talking massive. That starts with attitudes, but that starts with each and every one of us first. Yeah.
Thank you very much, and
welcome.
sorry that I took you off on the tangent.
But no, I'm easily led.
Many people reach out to us every day struggling, so it's an important issue.
Yeah, it is important.
Thank you. Linda?
Thank you. Some of what I actually had in my head has been covered, to be honest with you, particularly those last points and around that. So I was going to ask you, and I think you've just answered it, and I'm going to say the answer is not yet. So you talked about, that need to lean in rather than dig your heels in. And I was going to ask you, do you feel that there is a leaning in or still a dig your heels in attitude? And I'm talking about from departments, because I have seen where individual schools are doing outstanding work.
Yeah.
Like I give an example of St Mary's in Pomeroy here, who have, started off by setting up their own nurture unit funded by the school because the department wouldn't fund it, because they're a rural school and they don't fit into that, even though they had a quite a high rate given the small rural constituency that they live in, small rural area that they live in, a high number of looked after children as well. And they then, when they realised how valuable that nurture unit was, they decided what we actually need is a school that has a nurturing ethos. And it is outstanding. It is an outstanding example of how you could actually do exactly what you've just talked about, Emma, about let's put in place things before diagnosis, and that everybody actually can potentially benefit from, whether that's everybody in the classroom or everybody in the workplace or whatever it is. So I suppose just to get a sense of, do you feel there is any leaning in from the department, from the trusts, from the education authority, those different bodies?
There are pockets of very good practice, and I meet an immense range of professionals who have immense ambition and will to do better and do better for autistic population. But this rule has been a struggle, because what I hear from families and what I hear from autistic people, and then I go to the very services and supports that are delivering that, you would think that I was hopping from one planet to another. And I am struggling, and I've articulated this a number of times, to join the dots on people's experience and the individuals and systems delivering it. So, I mean, it's simply, I suppose, the system, the will is there, the ambition is there. I haven't encountered a particular defensive-ness, but it's just there's something else in our system. I don't want to say the system has failed, but I just can't yet join the dots between experience, the people who are in the services across health and social care. There's just something missing. Somebody needs to diagnose, I think. In terms of the nurturing ethos that you mentioned, I mean, again, that doesn't take massive amounts of resourcing or training, and who can argue against a nurturing ethos in a school? There has been quite a lot of narrative, and I've had a bit of backlash in relation to my commentary around, the rates and prevalence of autistic and neurodivergent individuals that we're now seeing. I think we're getting better at identifying needs. We're better at recognising that needs need to be supported. I see this as a progress. But the other element to all of this is that we live in a completely different world. We don't live in the same world that I lived in when I was growing up. It's volatile, it's very uncertain, it's chaotic, and it's very ambiguous. And we don't get much downtime as adults or children, so we have to adjust how we operate, and that's we just need to shift and move. And I would say in relation to the good practice and the defensiveness aspect, I think, and this is outside of my remit, but just it's come across as something that would be really beneficial, is a statutory duty of candour, and that having that as to really embed that culture of openness, I think would be really, really beneficial.
And is that in all public bodies? So I mean, obviously in England they're talking about bringing in we have looked at as a health committee the statutory duty of candour for the health department, but obviously we're now looking to, is it a better way to do it for all public services, a statutory duty of candour for all of them? What have you a view on which of those?
I'll be honest, I haven't developed a view. It's just I'm aware of the work that you've done in looking into statutory duty of candour as a health committee. But again, I mean, I can't see what defence there is about not having a culture of openness. And particularly, and I'm just thinking, I have two individuals in mind who have suffered greatly because of an entrenched view across different trusts, where an apology would have stopped years of torment, where people get trapped in a cycle of complaint, burnout, not being able to finish the complaint process.
We see that. We see that every day in every element of our health service. I don't think you're pushing an open door with the majority of this health committee. I'm going to say probably bar one. So I think that's well covered. No, look, I appreciate that. Thank you very much. Thank you.
Colin?
Oh, thank you, Chair, and thank you for your presentation. And again, just at this stage, most of what's been said has or needs to be said has been said. I just wanted to echo those remarks about how getting the diagnosis shouldn't be the gate to open to enable a whole load of other services, and particularly whenever we look at the expertise that there is within places such as schools, to sort of say to somebody, no, you can't get this until you've got this golden ticket, and it just seems like we're depriving them of an environment that would help them to flourish and develop, and it would be of much more benefit to them. And I think that's something that would be really good to see how we can investigate that and interrogate it. And where that kind of leads me to is there was one or two of us that were members of the health committee whenever we looked at the Autism Act a few years ago, and I've just brought it up in front of me, and I've looked at the list of roles and tasks that we asked for the independent reviewer to actually carry out, and it was, it says part 8 says the department must pay the reviewer expenses and allowances which are reasonably necessary in order to allow the reviewer to carry out their functions. And then it says next the functions of the autism reviewer, and it lists A, B, C, D, E, F, G. And how you're meant to do that on your current resources, I think, is it's just not possible to do things, to look at the effectiveness of the implementation of the strategy, to look at the funding arrangements that there are for autism, to keep under review practices relating to that. And the thing is that that's quite clear in a bill, it's quite clear in law what we have asked somebody to be and then what we've asked them to do. And maybe rather than keeping it going with a conversation, just to pick up on what Diane had said, I think maybe afterwards we should actually just look at contacting the department and say, hold on a minute, this assembly set in law a piece of work to be done, and we don't know how it could be possibly being done when we look at the resources that are currently allocated to it now. So I think that's something that would be worth picking up afterwards.
Can I just say as well, if you look at the bill, you will see the financial memorandum there. I can also say that I have read every single bit of progress and committee stage of both of the pieces of legislation, and I understand exactly what the intention of the Assembly was, and I want to honour that. But in terms as well, just as a caveat, when you read through the statutory functions, you have to remember that that's across all government departments. That is also across all sectors, and the remit is incredibly broad when you actually look at it. And my head of office and I spent considerable time looking at the legislation and the intention and the reach and the remit. So it is incredibly broad. I will also say in relation to the autism strategy itself, it is not. I did send out a briefing series, which I think may be in your pack. It's not aligned with the legislation. I accept that is probably a product of the landscape in which it emerged with COVID and the Assembly not sitting. But there's still 3 years left in the current strategy. My role at the minute, which I'm actively working on, is bringing all of the departments back on board. So I now have my own contacts within each department. Those introductory meetings will happen in due course. And I will support departments in the next 3 years to get really back on board. The autism strategy is health and education centric. it does not fulfil the responsibilities and duties that are in the legislation. It is falling massively short. We have what we have now, and there's a bit of time, I suppose 3 years, not ideal, but it will allow me to bring everybody back in. And I'm doing that in incremental steps. I'm not making reports with lots of recommendations. I want to see departments do one thing, that is give me a name contact, and we're almost there. So that's, I suppose, essentially where that. In terms of the cap number of hours, just to give you I know this is a frustration, this role was advertised, or the competition was advertised, and there was 2 years before I was appointed. And when you look at the remit, if you even just take across 9 departments, at a cap of 2.5 days a week with no help, it's impossible. Absolutely impossible. Now, I have pushed for the cap to go up, not by much, and I am whittling my way through that. In the first 6 months, I did essentially the capped year's work, and I could have done far more.
I think it's really important for us, given the importance that we as a committee put on that, and the importance of all that the evidence that we can see within the community, within the groups that we work with, and within the constituents that come to. I think it's important that we maybe amplify that thought through to the department, but we can pick that off afterwards. But thank you very much. Thank you.
Thank you, Alan.
Yeah, thank you. Emma, just listening to your journey from August 24, was it you started?
24, yes.
Yeah. You know, I have a mental picture of you walking into this office with a chair, a desk, and a keyboard.
Didn't even have that.
I didn't have that. I was given a phone and a laptop.
See, my mental picture then was wrong.
Yeah, just take away the desk.
Even worse than what I thought. But you said, I picked up in your earlier remarks that you did get a little bit of departmental admin assistance, which discontinued at the end of August. I don't know whether that was for 1 year, whether it was, but what's the reason why the department withdrew that?
It was simply that the individual moved on. I suppose my frustration is that's delighted someone got a promotion, but again it comes back to planning and the sustainability and resilience of an office that has essentially there's no contingency. And to be really clear, I mean, yes, the picture you said wasn't quite right. It was had less. I have fought for much, much more now. I do have one corner of civil service buildings to call my own. Not ideal, but it works for now. But it will only take one thing to make this office inoperable. And I don't mean that in an alarmist way. With only 2 people, and I don't have access to some of the systems that are required to run this office, and it is all hands on deck. So where my value should be is essentially elsewhere in administrative tasks and things like that.
I'm disappointed to hear that the person that you had, the department that supplied you, moved on for promotion. I can't understand why they wouldn't. It's a post. And why they wouldn't replace it, why they get just somebody moves on, so the post is just.
We will seek to refill that, but again, I mean, I don't want to sound like I'm complaining, because my experience in this role and in terms of resourcing is it's nothing compared to what families out there are experiencing, but it's not much of a surprise. But again, the effort that it takes within the capacity of myself and my head of office then to go about the process of recruiting that person is another that takes away.
You feel that department officials are giving you the respect that your office deserves at the moment, or do you feel that you feel a little bit cut adrift by the officials within the Department of Health? I mean, I'll add another couple of points to that. I mean, do you have a direct senior point of contact? And does the department facilitate regular update meetings between yourself and officials, where you get the opportunity to, to express where you feel the department's at?
And I have to be fair, if I request to meet with the Minister, he'll meet with me, and he's always open to meeting, as is the Permanent Secretary and other senior officials. But I had to make a difficult choice. Do I spend my time back and forth in those meetings, or do I just get on with the job? So I got on with the job, essentially.
But maybe with one hand tied behind your back, which is unfair.
Yeah, probably. I would say that.
Yeah.
I mean, I don't know where the department essentially sees me sitting in all of this, and perhaps my personality and my background as a lawyer just does not permit me to accept anything less than full fulfilment statute duties.
Yeah. Just to move on then to more practical outworking of autism and stuff. We talked there about the waiting times. In terms of a young adolescent on the waiting list, but they're coming up to the cut-off point where they become an adult, is the time that they spend on the waiting list, on the adolescent waiting list, is that credited to them when they move into the adult waiting list, or did they start from scratch?
I honestly don't know the answer to that question. I can find that out if
I
needs
think
be.
I'd like to know maybe just what the answer to that one is. The other one, again, it's really just a point of interest with me. It's not really maybe fair even to ask you the question, but the TV programme that we all watched about how loving parents were having to deal with young adolescents at maybe 13, 14 years of age, but daily growing in strength and stature and all the rest of it. And parents, particularly the mums, having to try and deal with the violent outbursts that those children just have, and it's not, can't fault them or blame them or point a finger at them. It's just part of their condition. But what happens when those young adolescents, go into adulthood and they become bigger and they become stronger, and maybe their mum and dad becomes weaker with age? What's the answer? What is the outlook for families? What is the outlook for the young person? And how do we? Is there a way of dealing with it, you feel?
Sorry, just to intervene, if you do feel it is an unfair question, feel free to.
I don't have a specific answer to the question, but what I will highlight from the question you've raised is that long before those young people reach adulthood, that the question in those parents' minds will be, what happens when I die? And that's a reality for many people and for many families, and they should know there should be a clear path. There are families who live with that question very, very early on, and when you look out into the system, it's incredibly frightening. I think I don't know that I can add much more to that, but I think you've touched on something very important, very, very important. That's a real human issue.
Thank you. I certainly appreciate the work that you've done today.
Thank you very much. Thank you.
Emma, thank you very much for coming. That was very insightful, and certainly a lot of concerns that you've raised we will be taking forward. So, thank you.
And any time the committee wishes to engage me at any time, I'm open to engagement to support your work as well in any way that I can.
Thank you, Emma.
Okay, thank you very much.
Okay, members, just to take up, I think Colin, you had raised it first, writing to the Minister, just with that, is anybody anything they want to add, comment-wise?
Or than she cuts a very frustrated figure.
Absolutely.
I just, again, not trying to play the long-term card, but definitely my sense of what we were looking for in the committee whenever we developed the bill was not somebody 2.5 days a week with one member of staff. I know we deliberately queried about calling it a commission, but we didn't. What we were advised that it would have come with a commission and could turn into a very large organisation, and that was felt that wasn't wanted. But I certainly don't think we meant it to be as pared back and as resourceless as has actually been there. And I don't know, maybe if I could ask Keith for a bit of I mean, is there any way that we can revisit what was the spirit of a committee's previous view as to what we are now seeing in action, to be able to say, I don't think that's what the committee was thinking of back then, somebody 2 and a bit days a week? And
Sure, absolutely. I had a quick look as well just at the financial memorandum, and it said that the thoughts around that time was the cost of the office would be somewhere between 300,000 and 500,000 a year. So it was. So
wow.
I think I know the chair had said about writing about that and seeing how much has been allocated in this year and how that compares to what the expectation maybe was.
That would have been what my remembrance was, that it was going to be something where there would be a commissioner, maybe 3 or 4 staff in a unit that was then looking at cross-departmental work, looking at community-based work, and trying to match that against the strategy to check that things were being delivered. But you know, and I remember meeting Emma about a year ago, and she was frustrated then, and that where a year later that frustration doesn't seem to have lessened. So.
Sorry, Chair, can I just also add that one of the things that I think that is very frustrating for her is the lack of communication and information. Mm-hmm. So if she's not getting information from the programme board on how respite, for example, and that 13 million is being implemented, then she cannot then report on her statutory duty as to, you know, how this aligns with the strategy, or how it aligns with the aims of the money that was implemented. So I think that there's something also, not just about resourcing, but there's something also about communication in relation to it. I mean, it is actually quite difficult to get a lot of information on this particular
Is that
issue.
communication, is it one directional, or should it be two-way? And if it's one directional from Emma's position, or even if it's two-way, if Emma's not properly resourced, it's tricky for her to, you know, be easy for us to sit and say, well, why is she not standing, blathering doors and saying, I want to know, will you tell me? If she doesn't have the time or resource
surely
to do
some of
that,
that should be automatic communication. It doesn't have to be that she's always running looking for it or whatever. If there's just that kind of open communication, I think is more. It's very hard to hold people to account if you're on your own trying to do a range of things over a huge range of departments. I mean, this relates to, you know, all departments here, and if you're on your own doing that, it's very difficult. So it's just about that kind of automatic communication.
It surprised me a bit, Chairman, that I asked if she had regular sort of sit-down meetings with, you know, officials, and I thought it would take me would be she would say no, she didn't have that facility, but she said, it quite surprised me, she said that she can pick the phone up anytime and meet with the permanent secretary and indeed even the minister. So, you know, it's maybe something that she really needs to take up at a high level, or it does seem to be a lack of communication.
She did say that she had briefed the minister on what resources she would need to completely fulfil the role. So, you know, she's done her bit of the communication on that side. What I'm hearing and what I've seen is there's not enough resources. So I suggest that, taking Colin's suggestion, that we actually write to the minister and we ask about the total cost allocated to the office, and the department's response to consideration for additional resources as outlined there. And the other thing she highlighted was her lack of knowledge on the oversight board, who was on it, what the role of it was, and the remit of it was. So if we could get some more information on that. And just on the last point, Diane, you raised, just about the amount of information that she is not getting, and that she is provided with adequate information.
And it's not just
in order
health.
to do the role.
No, our only remit is to health, but I suspect that she has a range of departments that she will want communication from. You know.
Members happy if we...
maybe yes. Oh, maybe I think you're just going to say it was about the cap. I'm trying to work out where that cap came from at 2.5 days per week. I don't think that was ever referenced in legislation. I don't think it was ever the intention that it would be a part-time post. Or so it would be interesting to know if she's having to deal with it, like a ceiling in the number of hours that she can do. Who implemented that? Who made the decision that it was only required for 2.5 days a week? And then why has that been translated to her? Because that I've never. It's not a concept that I've heard discussed, certainly from a legislative perspective, about it being a part-time post.
Okay. Window dressing. It's window dressing, isn't it?
Yeah.
If we could ask that as well. So are members happy if we take up all of those points with the Minister then? Yeah.
The other point maybe come up there, do we have concerns about whether the anticipated budget that was been allocated was actually been used or been granted to be used, or had somebody quietly cut it back? I think it maybe
word that into the first question.
Tease that out, yeah.
The total cost allocated compared to the anticipated budget. Yeah. Okay, members, if we'll take them forward as actions, and we'll move on to our next item. Item number 7 is the oral briefing on Cytology Screening Review. Refer members to papers at tab 7, page 178 of your main pack, and page 3 of the tabled papers. And I want to welcome the following officials. We have Professor Lourda Geoghegan, Deputy Chief Medical Officer from the Department of Health, Mr. Paul Cavanagh, Director of Hospital Commissioning from the SPPG, Dr. Joanne McClean, Director of Public Health and from the Public Health Agency, Dr. Stephen Austin, the Executive Medical Director of the Southern Health and Social Care Trust, and Ms. Moira Kearney, Interim Director of Cancer and Specialist Services at the Belfast Health and Social Care Trust. You're all very welcome. Thanks for coming. I'll let you get settled, and whenever you're ready, if you would want to make your initial remarks.
Thank you, Chair, and good afternoon, Chair and members. Thank you for inviting us today to come and talk about cervical screening, and you've just introduced my colleagues. Can I first of all give my apologies that my voice is not very good?
You're not the first one today, but there must be a bit of it about.
Yes. I lost my voice yesterday, so I've been trying to protect it, to have some discussion today. Just to reassure you, I am fully vaccinated, because I know at this time of the year we always are in the middle of our vaccination delivery programmes, so I'll do my best to keep going. So, Chair, I have a couple of opening remarks to make, and then happy to take questions and direct them to my colleagues as appropriate. I again want to start by acknowledging this is a very complex area, as we have acknowledged a number of times before, and we are very conscious of the people, the women, families and family members who are affected by this issue, and that remains a key focus for us. I also want to acknowledge that some of your questions I know will probably relate to some of the technical areas today, and we'll do our very best to answer the questions that you have. But in addressing the technical piece, we don't want to lose focus of the people and the patients that are at the fore of this work and continue to be at the fore of this work. At our last appearance in July, the committee had asked for a number of things, and just briefly, you had asked us to consider providing early access to reports that were to be published following our last attendance, and I can confirm that we did provide, we discussed that with Minister, and Minister asked that the organisations, that's PHA and Southern Trust, would provide early access to representatives from the Ladies with Letters group and any other family members that asked for early access in advance of the reports being published, and those were the reports published on the 5th of November. The committee had also asked for a copy of the Public Health Agency's reports in relation to quality assurance processes with laboratories, and that was supplied on the 1st of September. And the committee had requested information in relation to one of the steps in laboratory quality control. That's the data relating to the primary screener function, and that was shared with the committee on the 17th of July. So briefly to recap, 3 reports were published on the 5th of November. They were published by the Southern Health and Social Care Trust and the Public Health Agency. Those reports were an independent opinion on the previous reports, factual reports published in 2024. NHS England report of their peer review visit to the Public Health Agency addressing quality assurance, and the anonymised summary of the learning report of the Serious Adverse Incident Review that had been commissioned by the Southern Trust. And as outlined in Minister's statement on the 5th of November, he had asked that the reports will be published concurrently because they relate to all parts of the screening programme, and his request that they would be viewed in their entirety and also in conjunction with the previously published reports. The reports have provided clarity on some of the findings we highlight and will be happy to discuss with you do not necessarily align with findings of earlier reports. That does not mean that the findings set out in any one of the reports are taken account of more or less than any of the earlier reports. We acknowledge in this context that population screening in general, and particularly cervical screening, is particularly complex and can be quite technical, and it has taken considered analysis to really get to the point across all the reports of understanding the matters that occurred in this programme. It's clear from the work undertaken that there were significant issues in the Southern Trust laboratory as it provided services to the screening programme, and issues relating to the management processes in place at the time. There were also issues relating to the quality assurance function in the Public Health Agency, and I want to apologise on behalf of the Department for these failings. They are and were unacceptable. We would emphasise that the failings are historic, and a very significant amount of work has been done in the last 3 years to change and improve the cervical programme as it is currently delivered. And at this point, it's a much different programme and delivery than it was prior to the pandemic. All the recommendations of the RC Path report have been implemented. There's been full implementation of primary HPV screening into the pathway. And since November 24, one single regional laboratory service now provides service to the cervical screening programme, with primary HPV testing and cytology testing as a second line pathway, and that pathway is expected to pick up 90% of discrepancies. That would be 90 out of every 100 discrepancies. All recommendations arising from NH England peer review visit and from the other reports that have been published have either been fully implemented or in the process of being fully implemented. And you will be aware, Chair and members, that the Minister has asked Professor Sir Frank Atherton, previously Chief Medical Officer in Wales, to now undertake an assessment of the work completed to date. Professor Atherton is completely independent of the screening programme here. He will determine the methodology he wishes to use to meet Minister's request, and he'll provide his advice directly to the Minister. And it's expected his work will complete early in 2026. We have discussed previously, and I know everybody and members agree, it's essential that women continue to have confidence in the cervical screening programme and to attend when they're invited for screening. And it's equally important that anyone who develops symptoms seeks assistance through their GP, their primary care provider, or whoever else they're in touch with in the HSC. And I'd like to thank members and a number of advocates who've highlighted these important points in recent weeks as we all continue to encourage women to come forward to participate in screening. It's also really important that we continue to have high uptake rates in our vaccination programme, our HPV vaccination programme. And as you know, that's a school-based programme delivered to both boys and girls. So in closing, I want to say that I and my colleagues fully appreciate that this is at times a complex and technical issue. For example, when we're discussing parts of the technical parts of the screening pathway. At other times, it's a clear and straightforward issue. For example, when we're talking about people's experiences of our healthcare system and when we receive feedback in relation to how people have experienced the services. Throughout the process, the Minister and we remain conscious, as I said, that at the centre of this are women and their families who are impacted with the matters that arose in relation to this programme. And my colleagues here and I will do our best to answer the questions you have today, and I'll be happy to direct your questions to the appropriate colleagues depending on the area that you have questions in. So thank you, Chair.
Thank you, Professor Geoghegan. I absolutely would agree that there needs to be a high level of public trust and faith in the screening programme. And certainly, you know, that has taken a significant knock recently, and we have to do everything we can in order to rebuild that public trust, because, you know, it is vitally important that, you know, people do trust it and they do go to their screening appointments, and they know that, you know, they can trust the system. One thing, just while you were speaking there, that I'd heard you said that all the recommendations of the RC Path report have been implemented. Was one of the recommendations that all women received a retest?
Now, you may be referring to the recommendation which relates to the RC Path observation that significant numbers of women may have received false negative tests for the tests that were done in the Southern Trust Laboratory. I think that may be the recommendation that you're referring to. I hand over, Dr. Rosaline and Professor McClean chaired the group that oversaw that work, and I'll hand over to Stephen, who may want to comment, and then maybe Joanne.
I'll maybe start, maybe Joanne will come in as well. Thank you for the question. Yes, the recommendation was that there may have been abnormalities might have been missed in the Southern Trust lab that couldn't be picked in other labs, and so when we considered that, what that led to is the cervical cytology review, where we reviewed the case histories of all those 17,425 women, the vast majority of whom had their smear tests reviewed, because we still had those, and those who didn't have that, they had a call forward to get their latest status. So that led to that CCR review. So that was the implementation of that recommendation that effectively asked us to look at those women and provide some assurance for them, and that's how we did that.
Yeah, if I maybe come in as well, whenever you read the RC Path report, they did say that normally they would recommend that there is a review of the historic slides, but they didn't think that that was actually possible because of cytology capacity in Northern Ireland and indeed across the UK. But it happened at a time where we were just about to admit or start primary HPV testing, so we knew that our programme demand was going to fall from about 120,000 a year to about 14,000 cytology tests a year. So we did feel we had capacity to undertake the review. One of the reasons that we opted for that full review, which was what they said they would normally recommend, they just didn't think it was doable, was because we were very conscious that some women, particularly women from more disadvantaged groups, may not come forward again. So they may say, well, I don't really want to come forward for another smear. So we didn't want it to sort of fall prey to that. And in fact, it was good that we managed to get about 15,000 slides reviewed. There were a couple of thousand women, I think, who we didn't have a slide for, or there was an issue with the quality of their slide, and we had to invite them forward for a test. I can't remember what the uptake of that invitation was, but it wasn't as high as we would have wanted to be, and that was in spite of multiple follow-ups and communication with the ladies. And I think that was one of the key considerations that we had in deciding for the methodology that we would use just to assess the amount of risk within that group of women. So we thought it was a more comprehensive approach. It was what they would normally have recommended. They didn't think we could do it, but we reckoned we could do it, and we did do it. And the third thing was that just worry that people wouldn't come forward.
Okay. We can follow up just with that. So thank you for that answer. Something that does occur when you read the reports is that there is an identification of underperformance. I think there's one of the reports suggests that there is a perception of underperformance, and certainly it's been communicated to me that phraseology was very offensive to the women involved, and they did take that very hard. That identifies the underperformance but does not examine the reasons for the causes or the causes of the underperformance, such as workload models, overtime practices, supervision, training, data definitions, or managerial decision making. Have you any comment to make around that?
Well, I'll begin again. In the reports, I'm thinking particularly the SI report does draw attention to workload, particularly you mentioned workload, and that there was a lot of overtime used so that staff were working more than were, and that would be one factor potentially might have impacted on that as well. But there is a difference between the various reports in terms of the perception of underperformance as this quoted from that more recent report. And like from our viewpoint, I think there's no doubt there was underperformance of screeners. The difficulty is that because the lab processes have changed somewhat, and that's identified in the reports, it's actually difficult to quantify by how much. We know there's underperformance, but exactly how much is not as clear, and we're not able to tell that because we can't standardise our measures against measures used in England as such. But it does mean that there's underperformance, and obviously has impacted that for some women, and the SI report obviously describes some of that impact, and we're obviously very, very sorry for that. But there is impact, and I wouldn't get the impression that we didn't think there was impact. There absolutely was, and women were impacted, and we do recognise that very strongly.
Impacted and harmed.
Absolutely,
Severely
absolutely.
harmed. No problem. Just one issue. So we've effectively heard that there was underperformance, and you've apologised for that, and there was harm. Getting to the why of why there was underperformance, you've mentioned overtime there as well. One of the things was we'd heard that screening was being done at a rate that maybe it shouldn't have been. Was there an element of competitiveness involved here at all?
I don't think that's been described in any reports, an element of competitiveness, but certainly the workload that you've mentioned already, there are known factors that impact, when screeners work. So if there are strict limits to the length of time, so they shouldn't be working more than 5 hours in one day of screening, because again, you can just get overload, and you don't want to be working 7, 8 hours. So there's quite limits, and have to have rest breaks and so forth as well. So those factors are recognised, and they're part of the working pattern. But the individual screeners, the other thing I suppose is that we've mentioned before is that when performance was noted, there were steps put in place to try and resolve that, but they weren't adequate. And I think the last time I was at the committee, I did mention that we do apologise for that. The management of the underperformance was not sufficient. So that's another factor impacting this as well, that they didn't have sufficient management of that to make sure that the retraining was effective and that was monitored appropriately. And that's something that's become, and again, it's mentioned in the reports that were published on the 5th of November.
It was mentioned to us that there do seem to be significant inconsistencies in the reports. How do you explain that?
I'll say a couple of words, and then colleagues might want to. I don't think that, and that's why I mentioned in my opening lines, every report did not conclude exactly the same thing. That does not mean that one report is more important than the other. The areas that were looked at were across the whole screening programme. So some looked at core laboratory pieces, some looked at the management within the trust, some looked at the quality assurance, and then some looked at the population level. Screening is very complex, and we've talked before, the information and the data in relation to it is very complex. And depending on the way you look at the data, you can form differing opinions on things. I think what Stephen has referred to is it is clear from the reports that there was underperformance in the laboratory, no matter what way you look at this. And it's not that any one report's findings were taken over another or made more important than another. All of those reports together have informed what has been done and has informed the clarity we've been able to get about what actually happened and what emerged in the laboratory. The other piece that we just need to bear in mind is the laboratory had moved and had added in some additional tests and additional steps and had varied some of the timings, as you've mentioned. And it makes it very difficult to benchmark or get an assessment of things when that had happened. But the core point across the whole piece is that there was underperformance and it was not adequately managed over time.
Thank you. I'll bring in Diane.
Yes, thank you, Chair. And thank you yet again for meeting and talking to us about this. I've thought very carefully about this issue. I've met many of the women many times, and I've attended various meetings with some of them individually, and you know that as well. And when I read these reports, I kind of see a picture of a system that is underperforming. Screeners underperforming, managers and supervisors not properly supervising those people who are underperforming, not adequate reporting, and inadequate quality assurance from the Public Health Agency. Do you accept that you have failed women in this sense?
Maybe I'll start if colleagues want to. I think across all of the 6 reports, what is clear is that there were failings. There was underperformance. The management of the underperformance was not as it should have been, and across the pathway of screening, including the quality assurance, there were things that could have been done better. And in that context, and people were impacted, and in that context, that service has not served those people well. I don't know if you want to.
So I would echo that. I mean, the first thing, we've talked about it before, is that there are women who have experienced extreme harm because of some of the issues that are referred to in the reports. I am really sorry on behalf of the Public Health Agency of the contribution that the shortcomings within our QA processes contributed to that failure of the system.
Well, absolutely. I will apologise again for that, because it is really important. Like, people were harmed. I suppose it's one thing that I think is particularly clear is whenever you're underperforming, that wasn't managed, and I've mentioned that already. We would like to point out, I suppose, though, however, that the system has been effective for the women that did serve well, because a number of cancers have been picked up on another woman, and they've got treatment. But what is really sad, I think, is, and I think you're drawing attention to that, for some women that didn't work for them, so it didn't work comprehensively for all women. And I think that's the thing that we need to bear in mind, is that we need to make sure the system going forward is addressed, so that we make sure we fix those bits to make sure that those women, similar women in the future, do not have to suffer this. I think it's really important when you listen to the ladies and particularly the stories and accounts that are in those reports. They are harrowing to see, and we wouldn't want any other person to have to suffer that. So that's why it's so important, and we need to redouble our efforts to make sure the learning is put in place to make sure the system goes forward. Now, we do have an improved system with the prime HPV screening. Nevertheless, I think we need to make sure that the issues that you raise about the governance, underperformance and so forth are firmly addressed, and so we can have confidence going forward. And I can assure you that those measures are already being put in place going forward. But we need to make sure that's done, and make sure they're followed up to make sure they're done in detail, and I'll be happy to report on that in the future when that work is completed.
Okay. I suppose when I speak to some of the women, it's hard to escape the notion that many of them think of the reports as a kind of a damage limitation exercise. And that is very, very unfortunate. And part of that is because the women's voices are not heard in these reports. There is no conversation with the women. These are reviews of reviews, and I think that is one of the greatest failings of where we are now. There has been no forum where those women or their families, should they choose to, some may not, should they choose to, can have their voice heard. And I think that is one of the failings of this whole process, and as to where we are now. And I suppose the other failing that has been said to me repeatedly since the release of these reports is that there's a lot of things around, people were not supervised correctly, quality assurance meetings were not done correctly, they were not recorded correctly, and if you don't record it, you can't manage or monitor how actually you improve performance. So all of those things are failures on behalf of that, but there's no accountability. And that's a huge issue. How on earth, who was responsible that this was allowed to happen? What was the culture in the trust, in the Public Health Agency, that people were allowed to go to meetings with the Southern Trust but not record the meetings, not actually be able to monitor from one visit to the other? What was the culture? Who was accountable for the fact that screeners could underperform? And nobody was curious as to why they were underperforming one year and underperforming the next year. Nobody looked across the years to see why this was happening. And there is no accountability in these reports. And I think that is a huge failing in the reports. And I think, personally, I believe that the only way to get that accountability is with a full inquiry so that we understand exactly what happened. But I think that accountability is missing here as well. And I'd just like your view on that.
I think I would start by saying I am sorry if the perception is of the reports and the work done to date that it has been damage limitation. I can assure you that is not where Minister or any of us who have been working on this are coming from. It is technical and complex, and by its nature we end up talking about processes and systems, and I accept that to somebody who's been impacted by this, the processes and systems don't mean anything to them because they have been so impacted by it. But I can assure all members that this has not been about damage limitation from the work that we've been doing and all of the reports. It's been about really understanding and getting clarity about what was going on and what actually happened. And it has taken longer than we would have wanted to take, but it has necessitated us to look across all parts of the screening pathway to actually really get a proper sense of what was happening. So I am sorry that the events occurred, first of all, but I can assure you that damage limitation has never been at the centre of what we've been doing. At the centre of what we've been doing is trying to understand what has gone wrong across the piece and also use that to inform all of the changes that have gone into the programme to make sure it's a robust programme going forward and to support women and their health going forward. In terms of accountability, do you want to maybe say something and then I'll ask Stephen to?
And equally, I'm very sorry on behalf of the Public Health Agency. For me, as someone who has been involved in this for a number of years, our focus has really been to get to the bottom of what the issues were so we could improve going forward. And lots of the improvements have happened, like primary HPV, moving to a single laboratory. I hear the comment about damage limitation. From a Public Health Agency point of view, that wasn't an intention at all. I think that the NHS England review of our QA function, I really welcome it. I think it's pretty hard hitting, and it makes a number of important recommendations and identifies the weaknesses, I think, quite well. Our focus, we accept all the recommendations and will implement all the recommendations, and our focus is on improving that. On the point about involvement of the women, that is something that I feel very uncomfortable with you saying that, because I can understand perhaps how women might feel like that. I know individual women would have had an opportunity through the SAI process to engage in their particular cases, but it's something that I'm very happy to take away and consider how we could improve that. And also one of the improvements and one of the things that came out really, really strongly in the SAI report is the terrible experience that women had whenever they went to meetings about where they were going to be told news that perhaps their cancer could have been spotted earlier and maybe their outcome would have been better. They wouldn't have needed such extensive treatment. And the stories that we've heard about that are awful. There's no way of saying what happened was okay. So we really, really want to improve in that, and it's vital actually that we get women's input going forward. We do have a piece of work that is ongoing at the minute, and I have brought in a very senior person with psychology background, a very senior nurse with experience in this area to lead that work on my behalf. And I want to get to a place where that just doesn't happen again. That everyone who is diagnosed with invasive cervical cancer understands the purpose of the audit, understands everything about their journey, and that the imparting of information about their diagnosis is done in an appropriate and sensitive way and that they are supported. So I really want to make sure that the experiences that we have seen in that regard in the SAI never happen again.
Okay. Can I just share with your leave, make just one comment? It is really rather ironic that we're talking about an improved system when actually the trust that was awarded the new contract for the regional cervical screening system is actually sending the HPV tests to Gateshead in London because it can't process, or Gateshead in Newcastle, because it can't process them themselves. Actually, doctors, GPs are saying to me that they're getting results back quicker from Gateshead than they did from Belfast. So it is a bit ironic that that's the position we find ourselves in.
I might ask Moira to come in on the laboratory piece currently in the Belfast Trust.
I'll probably start with the equipment issue and then maybe go on to some figures if that helps as well. It's not where we want to be either, with equipment that is past its date for replacement. The equipment that we were supposed to have to set up the lab, no matter where the lab would have been, is part of the CellPath tender contract. I'll let Paul, he'll come in relation to that. We have been unable to get that yet because the tender hasn't been awarded. So when we set up the lab last November, we inherited equipment from the Northern Trust to help us with that, and a second piece of equipment, that's pre-analyzer and the analyzer from some of the virology from the COVID equipment that we had. That is not where any of us want to be. It's not where my staff want to be, and it's not where I want to be for the women to deliver that. As you said, we sent some samples off at the beginning of the journey that came from the Western Trust and the Northern Trust, around 5,000. Then if we moved to July, or around July, we had about 89% of our samples back within the 2 weeks, which is the target, so we're 1% off, which was great, even though the equipment was old. The equipment then started to break down more than we thought and more than we wanted to do. So we then did a deep dive into the equipment that we had, waiting on the new equipment coming in. Could we make that better? And we made the decision that it was right to move those samples to Gateshead so there wasn't a delay for the women. Thankfully, the equipment is now up and running again, but we're still waiting on the new equipment, so it's not where any of us want to be. Just to give you some figures, since we set up the lab last year, in totality, there's been 116,000, just over 116,000 samples. 18,000 of which were done in Gateshead, so I need to recognise that. The 5 at the beginning and the 13 from September onwards, as we've talked about, around about 50%, and we were commissioned for 120,000. So you're right, this is not where we want to be, it's not where my staff want to be, and it's not what the women of Northern Ireland deserve. But we also would always have a contingency plan for any of our equipment in the lab services where if any piece of equipment broke down for anything, we want to have that contingency so that the delay isn't greater.
I really just want to come in there very quickly because I don't want this to be about the new, I'm not really, but it just sort of, I find it ironic that we're saying we have a better system when we actually have a collapsing IT system and system for doing the tests. And like, I'm just making that point. It's you know, we should have looked at these things and made sure that these were working and fit for purpose as well. So you know, we had a system that let women down before that, and we have a system that's still not functioning properly. You know, it should be better, but it's still not functioning properly. And I'm not terribly sure we can say we've really done that well in relation to it.
To update just maybe.
If I might just briefly, I understand the point you're making. The Trust have done their best in the circumstances because the equipment is aging. We do need to replace it. We have been in the process of what has been proven quite a protracted process of procurement of equipment for cellular pathology, which includes cytology. But we now know, given some of the challenges the Trust have had over the last couple of months, we're now looking at actually those specific pieces of equipment and quickly procuring those. So we are in the process now of trying to work with the Belfast Trust to move that on. But I accept the point that you're making generally in relation to it, but we are trying to resolve that quickly rather than wait for the complete procurement to be completed.
So can I just ask then, leads me to another question. So this was a multi-million pound contract that the Belfast Trust won to deliver these tests. Who pays for the new equipment?
Yeah, the department.
And is that standard in all of these issues?
Absolutely, yeah.
Okay. Folks, thank you very much.
Thank you.
Folks, Nuala.
Thank you very much for coming in front of us again today. Can I take a little bit of a step back at first, just to kind of outline a wee bit of the understanding of the process, because we often talk about, you know, questions are about equipment, but actually a lot of the equipment, and then on the other hand, screeners. So the pre-COVID slides and then the current day. So pre-COVID era, it was manual. A screener was a person looking at a slide, and equipment still needed, of course, to do that. But it was an actual individual and a person who looked at every slide. Is that correct? Yeah. And what was the standard for, and we can't have 100%, we don't expect there to be 100% absolutely everything's right all the time. Nobody expects that. We'd like it, but there's the real world. But what was the standard kind of time in which you should allocate to look at individual slides whenever it comes to
I'll say a couple of opening words and then I'll hand over to Stephen. So the pathway up to 2023 was cytology based, as you've said, and that's where a slide is made and has to be looked at under a microscope. Yeah. And that the pathway, that was for all samples coming in through the pathway. And using a pathway, the overall pathway, which is cytology based, you would expect to be 75% effective. So it would pick up 75 out of every 100 discrepancies, the overall pathway. But that was a slide and a person looking at it, okay, in the laboratory. And then the national screening parameters advise on the first screen, the checkers, and then if there's a rescreen needed, and they advise the times and the parameters around which you're supposed to apply to each part of the screening piece.
Every slide that was taken from a woman's smear test was looked at, am I correct, should be looked at 3 times? Or from what you said there?
Not all of them would be 3 times. Do you want to?
And I suppose whenever they look at the slide the first time, roughly the screeners look at roughly 8 slides an hour, so that's roughly about 8 minutes, but some will be quicker than others. So if you spot an abnormality more quickly, obviously then you'll be able to grade it as high grade and you get the answer already. Other ones take a bit longer to do, so there's a variation. So there's no real specific time, but we expect about 8 minutes. But the person looking at it, it's worth remembering that's a subjective test. So you're looking at them, they look at the slides, and it's not that it's all clear and then they suddenly spot something abnormal. There's normal cells in the middle of that, there's inflammation, and there's lots of things they have to try and distinguish that and try and spot something, a bit like a needle in a haystack, and they have to systematically look across the slide and actually look down in and out the slide as well. And so there's a bit of subjectivity, which is the reason why they don't pick up 100%, and it's 75% are picked up. And so the time itself varies, and but that's the first stage. Then the second stage then is the rapid review, where the second screener will look at the slide for a shorter period of time, and that's round about 1.5 minutes, 90 seconds or so. They'll look at that, and basically it's to confirm the previous findings. So, and they'll look at that as well. Now, in the midst of all, there's a bit of quality control as well. Occasionally, some slides will be looked at again, fully looked at for very, very small numbers.
Sampling of
some. Yeah, there's a bit of that as well goes on in any system like that. But that's roughly what goes on. In the new system, the advantage of it is because you're doing basically a biochemical type test, the subjectivity is gone. You're either positive or not with HPV, so that allows you to refine down the slides you look at with cytology, because then you know there's potentially an issue there, and you can look more carefully at a small number of slides. So that's the advantage of doing that. But we know that pathway picks up 90%, so it's substantially better for women. But the old pathway, you're quite right, it's there's a variability in it. That's one of the reasons where we are and why we need to go to the new system. Okay. I hope that answers.
Yes, no, it does. It does. I think it's just important to get to the very basics of where kind of things went wrong, but also you have to understand how it works. And if you're saying 8 minutes a slide, but could be less, sometimes possibly even more. I mean, we have seen that there were times where there were screeners doing 2 minutes per slide on the first. And was there a target to be met with regards to the number of slides that you had to do per shift or anything? Or was it just you were continuous? Or was there targets to be met?
So obviously I wasn't there at the time, but my understanding is that it's expected that the screeners would look at 8 slides per hour, and that works out about 8-ish minutes, roughly that sort of level, 7-8 slides an hour, and that's roughly about 8 minutes. That's the expectation. So you would expect that over a course of a day, if they're working for 5 hours, they're going to look at 5 times that, so 5 by 7, 35 slides, that sort of level. You wouldn't be expecting them to look at more than that, because as I said, then it would make you think that they were overworking and looking at them too long. So that's the sort of numbers. But some days they might have worked for 4 days and you worked 25 slides. So you wouldn't expect them to be doing 100 slides in a day. Absolutely not.
And was it that increase in the number of slides that some performers or some screeners were doing that raised the very first kind of flag around we need to actually take a look at what's happening here?
No, I think what, having spoken to some of the staff involved, not just the medical staff, their curiosity was raised because they'd seen a particular case and they thought, and they looked at it and there was a new member of staff had come in and had been appointed, and they'd looked at that and just raised a question in their mind, and then they began to look back, and then that's when they raised the concerns within the trust. So sometimes maybe it's fresh eyes in a particular case and that more curious mind and new staff coming in certainly was a benefit, and that's what we encourage the staff to be now, is to be curious at all times. But I think that alerted them to that. It wasn't necessarily about times they just looked at this line and thought, what is here is a pattern they'd spotted, and then they looked back a bit more and their own observation, and then thought there's something here, and then they raised that matter, and then it was further looked at.
And I think that's important because it's not nothing you can answer really because you weren't there, but before his time when he raised and he's already been on the news and everything, it's well known, raised the initial flag. I'm sure it didn't happen just straight away. It wasn't all of a sudden. We now know because the evidence, it wasn't a sudden increase in either looking at slides or underperformance. But we do need to, and this is why I support the call for a further inquiry to actually bring the people in who were listened to or who were there at the time, because how can we miss out? How was that flag missed out before that date? Like how did we not look at either the number of slides that certain screeners were looking at whenever it was well above, and at times the average, or whenever we had been told by the trust had told the PHA that concerns raised before in 2019, we didn't have to listen to them.
I think one of the things we must remember that all this is obviously historical now, thankfully, because we're in the new system, but going back, when you go back in the years, and some of the data we have was published back to 2008, as you're aware, the system's in place, and the screening programme has changed over that time. There's been a number of revisions to the guidance and the way the stuff, the slides have been looked at and the tests have changed over the course of the time. So, and the volume of slides changes as well. So there have been changes in the system along the way, But in terms of the curiosity, I think what you're asking me, was there curiosity before that? One of the difficulties, I suppose, if you're in a system and you're developing it going forward over a long length of time, this has been in, like colleagues will say about this, cytology been developing for many, many years, 20, 30 years. The staff are working in that, trying to improve it continuously, and they're always doing that. But the system is developing and getting more complex, more accurate through the years. And I suppose the curiosity you have, they're looking at improvements they can put in place. And did they notice the individual cases in the same way that more recently done? Well, obviously not, because we didn't have those concerns raised at that time. Having said that, there was a longer history at this time. Whenever the new consultant looked at it, there was a longer history to look at. So it's difficult to say that. Whether would a curiosity picked up then, we'll never really know.
It kind of brings me to ask, I mean, this is rightly focused on cervical screening, but given it was so labour intensive with individuals, are there other areas of healthcare in particular where this kind of intensive screening takes place and it's under people under a microscope? And have we moved on enough that this isn't happening or occurring, and there's safeguards for other areas?
So overall we have 8 screening programmes. They're not all cancer-related programmes. There are 3 cancer-related programmes. And then we have other programmes such as diabetic retinopathy, aortic aneurysm, but we have breast cancer, cervical cancer, bowel cancer screening. They're not all as microbiology or as laboratory focused. Do you want to say something? The Public Health Agency is involved in all of them.
Yeah, I think cervical screening is probably the most complex of the screening programmes, particularly in the past, because the sheer amount of sort of person work, which is very subjective, which is something we've talked about before. There is a subjective aspect to it. So the bowel cancer screening programme is a laboratory test. So you send your sample in, and it's a laboratory to biochemical test. So you're taking away that subjective
kind of element out of it. The breast cancer screening programme relies on mammography, so it's x-rays. So again, you have radiologists looking at those x-rays and identifying abnormalities. So there certainly is there's a level of human judgment involved in the breast screening programme, but again, lots of safeguards around that. And you may be aware that there are trials at national level to kind of look at what the role of artificial intelligence and other, maybe because anywhere you have a human, even the best human in the world, they will miss things occasionally. But again, there are safeguards and checks and things in place with the breast cancer programme, but the bowel cancer one is a laboratory test. Thank you, that is helpful. And my last question is around the quality assurance and commissioning role then of the PHA at the time and now, and with regards to any differences or safeguards, if you might kind of explain the difference back in, when it was first flagged, 2019 onwards, and then now. And we often, because the reason I ask is we often ask questions in this committee of people for accountability and oversight, but then their oversight bodies, sometimes played roles further down the chain in the structures, and it is difficult when you don't have the direct separation of roles and responsibilities. So perhaps you can provide a wee bit of feedback on the difference now and then between quality assurance and commissioning, but also what safeguards are. Okay, so the NHS England report that looked at the role of the PHA and the quality assurance of the cervical screening programme, it looked at a very long time period, because we asked them to look at the entire time period about which there had been concerns in the Southern Trust, and that went right back to 2008. And I think that the report of it concludes that there are some things well done and there are areas for improvement. But I think the other thing that it did note was that there had been significant changes throughout that sort of almost 20-year period. Actually, lots of things had changed during that, and lots of things had improved, particularly in the past 3 years. So whenever I look, and I'll maybe just use the example of the things that are highlighted in the report as areas for improvement, whenever I look at the particular comments that they make around the Southern Trust, for example, because we did ask them to have a look at it in particular, there were occasions whenever the quality assurance team identified issues with the laboratory in the Southern Trust. So for example, they identified this issue where there were all these additional steps being put in, and whenever the report went back to the Trust, the report was quite soft in its language, so it maybe said, consider this, rather than a more directive kind of, these are the standards, this is the way you must do it. So I think there's something around tightening all that up. There are 6 recommendations in the report, and some of them relate to just being really specific and clear around what standards we expect trusts to follow, how we're going to measure them, and how we're going to assess the measurement. We need to be much clearer on that, because it just wasn't as clear. I think there are also things around making sure that we get reports out in a more timely way, formally into trusts, and where actions aren't being taken, and that's being escalated properly up through the trust, so that it would come up through their executive team to Stephen and board colleagues, that they would be aware of issues in it. And I think that those are steps that we have moved on already. A big difference is the move to one lab, because at the point in time, sort of in the period that this is covering, there were 4 laboratories involved in cervical screening. So you were multiplying this activity times 4. The team who were undertaking the quality assurance in the PHA were small, too small. There weren't enough people on it. And they are things that we've already addressed. So we have moved down to one laboratory. We have made sure that that team is better resourced. It's much better resourced in the last few years than it was historically. And we have also employed senior manager people at assistant director level to be responsible for the quality and the improvement of the QA process, which is recommended in the report, but also to strengthen our commissioning arrangements. So one of the things that it talks about in the report is the need to kind of disentangle the quality assurance and the people who do that a little bit from the commissioning. But I think there's a real one of the messages that comes out to me is that we need to be much clearer and specify what it is we're commissioning and what we expect from the now single laboratory. So that is ongoing improvement. Our board has accepted all the recommendations, and as an organisation we have sort of re-profiled our staffing resource to put more staff into this area. Okay. Well, I think that's reasonable and fair enough. It's obviously unfortunate the reason why, but I think that progress has to be welcomed. And my final quick question is just that through the individualised and redacted SAIs that we've seen and the reports, can you concretely say at this time where we are that there was a stage in which intervention should have occurred? And I think in particular about Lindsay and Erin's case, not getting into individual cases, but for me, I think intervention could have saved lives, and I think of those two. But overall, have we now got an indication of a time in which earlier intervention should actually have occurred, and this wouldn't have happened? Do we?
When you look at the individual cases, and the individual ladies get their own story, it's clearly identified in them where they feel that a slide was not read correctly at a particular time period. So if that, the first date would be the first opportunity for the cancer in this case to be investigated to see whether they're cancer and get pre-treatment and so forth for that. So I suppose that's clearly in those reports. But
I mean, because you could easily have, not easily, I don't mean to sound dismissive in that and saying that, but you could easily have a mistake or a couple of mistakes. But in terms of the whole, what we've come to call it, the cervical screening scandal, is there a point that we think intervention, or we have come to conclusion intervention should have occurred at this stage to prevent the...
I'll maybe just say a general commentary on that, and Stephen may wish to come in, or Joanne may wish to come in. One of the challenges in this, and why it's needed, the detailed work it's needed, is to really get to grips with what actually was happening. So we've got a pathway which would be expected to pick up 75 out of every 100 discrepancies. We have a laboratory which has moved and added in some additional processes and systems, pulling it away from what the national expectation would be, which interrupts any potential benchmarking. And then we have evidence of, or you can see through the reports, times in which things would have been highlighted and flagged, but you've got a gradual veering in moving away from what should have been done as per national guidance. So to actually pick out a distinct time, I think is going to be quite challenging. I think what I would say overall is I think we would have wanted to have gotten to the bottom of this much, much quicker. Mm-hmm. And getting all of the detailed pieces of work done has taken time and has taken more time than we would have wanted, but I do think we would have wanted to get to this quicker. Do you have anything else to add to that?
Yeah, I think it'd be very difficult because we do know we're only going to pick up 75% with the old pathway of the abnormalities. So there will be cases that are missed as part of it. And trying to figure out where there's been a particular error made and where there's been other issues in the system that have failed, I think it's going to be very, very challenging in the midst of that. On the other hand, I suppose we are clear about where the changes need to be going forward, and that's really crystal clear from the various reports, and the recommendations are challenging, but I think they're the right ones to do because they're very much focused on making the service work for women, either if you're getting screening or if you have cancer, that you get the results of the audits very quickly, and that's done in a compassionate way. So I think there's substantial improvements there for that. But trying to pin down the exact date, I think, Nuala, would be exceptionally difficult, probably not possible.
Of course, just before we conclude, just to say, Professor Atherton will look across all the work that was done, and he may have a view. And if he, Minister will be advised and guided by his view. If he looks, again now with fresh eyes to see in that point.
Enough. Alan Robinson.
Thanks, Chair. I think the family members and the loved ones who were harmed will expect nothing more than me to ask, what is the resistance to a statutory public inquiry?
Well, I don't want to put words in Minister's mouth. Obviously, I work in the department and advise Minister. However, I don't detect that there is a resistance to a statutory inquiry. Where we are and have been in terms of advising ministers to understand what exactly happened and why it happened, and the steps we've been taken have been to advise minister in that regard. And I think minister has consistently said, and he's kept the questions that he wants to know in, and he's consistently said that he hasn't made a final decision. So I don't feel that certainly I or any of my senior colleagues at departmental level have been in a place where saying we would resist. It's about advising minister per the questions and the steps that he has been asked us to take.
Then maybe a better question then. If the current minister or a new minister is encouraged to support a statutory public inquiry, will everyone fully support that public inquiry?
It is a minister's purview to make the decision. Minister makes all the decisions and policy and advises us as senior officials, and that's our roles are to advise and support the minister.
Could you just refresh my memory, Lourda? How many screeners were underperforming? How many were there?
So Stephen has the summary. My understanding is at the time the RC Path report was looking at, there were 14 screeners overall, but not 14 overall in the laboratory. Do you want to maybe
there were 14 screeners overall, but the concerns originally raised back in October 21 about one screener, and they were removed from screening. Then there was a second screener asked to come off screening as well, so they were removed from screening also. And the RC Path report looked at it. They felt that when they reviewed it, there was two screeners particularly, which I've mentioned, were the main concerns. There was a further screener. I think they felt there was also potential concern on a fourth one who had screened for a very short period of time. But the main concern was on the two screeners in the RC pathway. He had it two in particular, I think. There's no concerns about the other screeners that were raised by any reports we've mentioned so far. But but certainly there was two in particular that I think that were well aware of. I think they're well described in the RC Path report.
Was there any malpractice involved? And was anybody referred to any professional bodies?
So,
at any level, management level?
So can you ask, I didn't quite hear what you said, sorry. Yeah.
Was there any malpractice?
So in terms of the screening and reading the screenings, no, there was no malpractice. What we've looked at was the performance was the issues that were being highlighted to the by the medical staff, and they were worried about the misses of slides, and then they looked back at the screening figures, and that's the thing that they looked at. So those are the matters that are being dealt with. And I'm aware that some of the screeners cases are being reviewed by the HCPC, which is the regulatory body. And the Trust is fully cooperating with the work of that body. So,
another question I know the families have been keen for us to pose. How can women be confident that the PHA is the effective and proper regulator of cervical screening?
So we're not the
regulator.
So I suppose PHAs, we're not the regulator. We commission the programmes from the trusts, and then we undertake a quality assurance function in line with national standards for screening programmes. I think that the areas for improvement in our QA processes have been well highlighted by the NHS England report. They did note that there were important strengths to what was happening. I think with the implementation of the recommendations, that quality assurance activity will be further strengthened. And I think it's important that we recognise as well that the quality assurance team did highlight issues with different aspects of what was going on in that particular laboratory over a number of years. I think that there were things would be improved in the future is how those were documented, formally communicated to the trust, and then escalated to make sure that the improvements and the changes happen. I think that's where the difference was. And as explained to Nuala, I do feel that this team historically was under-resourced, and the importance and the difficulty and the amount of work that needs to go into a quality assurance function perhaps wasn't maybe recognised in the past. we have made sure that the team is much better resourced going forward, and the function is happening with one laboratory. But there is one thing that I need to really make clear. The responsibility for the management of staff, the responsibility for the performance and quality of services does lie with the trusts. So the improvements need to come from there. And moving forward, one of the things that is an important improvement going forward is how underperformance. The Belfast Trust have a very detailed protocol around how underperformance is managed and what happens if someone underperforms in a quarter, the steps that are taken. It's all very clearly looked at, and performance is looked at over on a rolling basis over, I think it's 5 years. So I think things have changed quite a lot since the period of issue. But so.
Question then to yourself, Joanne. The new equipment, when?
Moira,
sorry.
Okay.
The new equipment, when can we expect that to be in place?
And again, Paul can answer that. We're waiting on it coming to us.
I mean, there is a lead time for the new equipment, so I think we have to emphasise that. I'm not sure exactly what the lead time is, but we certainly over the next 2 months are looking to try and finalise all of the kind of resource requirements in relation to it, Alan. So we are trying to move at pace in relation to it. Procurement can be a slow process, I have to emphasise, but on this occasion I think there is options, Moira, where you can use existing frameworks. So we're hopeful that we can do that at pace.
And should be the spring of the year?
It would have to be, yeah.
Probably, sorry, I misunderstood your question. So yes, once we get the go-ahead to go, we will go ahead and order, and then we'll get, I want to say, the space ready. We may not have the final area ready, but we're actually already looking for a temporary space to get the new equipment in, and then build the new space, and that's why it's hard with times, depending on when that builds up. So
that in itself will maybe bring some confidence to women out there too.
Yeah.
To the women and to the service, absolutely.
Thank you, Alan.
Thanks very much, Chair. Moira, in relation to the equipment that has been breaking down and letting you down over recent months, can you confirm that those breakdowns has not in any way compromised the quality of screening, but rather has just slowed down the throughput of screening?
So and Joanne will come in with this as well. We would have the quality assurance there, but like what was described, that we would do some tests throughout that. We feed back our information in through the PHA with the guidance that are there. My understanding, and yeah, I would say no, it hasn't. The big thing is a turnaround time for our patients and our women to get the samples back.
That's what I thought. And Paul, in terms of the procurement of the equipment, are you having to go outside the United Kingdom to procure it? Is it an international?
I really don't know is the honest answer, but I wouldn't imagine so.
Right.
To be honest, there's other people who are experts in procurement, not me, to be honest, but I wouldn't expect more that would be the expectation, but can't be certain.
There are already companies on the national framework for all pieces of equipment that are already there in the UK, so we would be hoping they would be our suppliers going forward.
Yeah. Alan has asked the question. My next question to Paul would have been what was the sort of full commissioning timescale, but I can take it that it's, whilst you're not been able to definitive, you are moving at pace, and it will be
in relation to the Belfast,
as quickly as possible.
The Belfast Trust equipment required specifically in relation to cervical screening. We are moving at pace. There are other cellular pathology equipment that we need to procure for the region, and we're continuing to work on that. But we're effectively lifting the Belfast piece out at this stage, specifically in relation to the cytology. So we're trying to move at pace in the knowledge that the Belfast equipment has become unreliable more, I think is probably the terminology. Yeah.
And Professor, just my final question. There does seem to be a growing perception that the Minister is not going to establish a public inquiry, but can you confirm that there are a number of options live in front of the Minister for a final decision, and that list includes a full public inquiry?
Will be guided by whatever Minister's decision is in this regard, just as I've just had the conversation. Sir Frank Atherton will look across all the work that has done. He will advise Minister, and Minister will want to see if Sir Frank's opinion answers the questions that need to be answered. What happened? Why did it happen? Who was responsible? And if appropriate steps been taken to make sure it doesn't happen again.
But a public inquiry is not off the table at this point.
As I said, we will be guided by what Minister's decision is when he gets all of the information together.
Thank you.
Okay, Alan. I just want to give a brief summary. We've been through a lot there. So I just want to give a brief summary as I see it. There has been long-standing underperformance of screening, and this was due to mismanagement, and we've heard apologies from yourselves today. The quality assurance didn't work in this case. Significant and serious harm was caused to a group of women, and they were failed by the system. Disclosure meetings were described in the reports as re-traumatising, intimidating, triggering and causing unnecessary fear and anxiety to those women. And now we have a series of reports that do not satisfy the women who were affected. That's at each stage there's significant feelings there, and I find this whole issue very, very troubling, that at each stage we are finding those significant feelings. One thing that occurs to me is that we haven't heard the why, and I know you've said about Professor Atherton's report that should identify the why. I don't think we've heard why this has happened. I don't think we've got to that, and I know the women want to know that, and that is the key thing they want to get to. One last question about something that came up earlier. I think somebody had mentioned about the culture. I think it was Diane, about the culture. Could I ask you what the culture was like in the labs? Was it a good place to work? Were there good relationships? Was there a good relationship between the lab and the PHA? Were there any reports of relationship problems, bullying, or toxic culture?
So I can't comment on the culture piece. Stephen, do you want to comment on your perspective?
Obviously, that would be back time, but I've seen no reports of, as you described. I can give you an idea what the current culture is like.
Mm-hmm.
And the current culture is the staff are inquisitive. I've met with them quite recently, last week and again this week, looking at these things. They're giving me all the information I need in a timely way. They're interested to understand this. They're interested to look at the reports. They're reading them, reflecting on them, so that they are very much in the space of trying to learn from this. So I'm just going to show you that, because that is something I've got from the members of staff. I have met a number of them recently about that.
And previously, have you any information or any
Well, I wouldn't have met the members of staff prior to that, but there's no information that I've heard that suggests there was, as you say, a culture of bullying or such like. No.
You haven't heard
I haven't heard that, no.
Okay, anybody else like to answer?
Well, I suppose a bit like Stephen, I can comment on the culture that we have at the minute and the culture that I would want to see.
Mm-hmm.
I think the very fact that I and the agency really want to get to the bottom of what happened here, why it happened, and make sure it didn't happen again. I think relationships with the new provider, with Belfast Lab, around how they're doing their work and their performance, and we're about to sort of embark on the first sort of year's quality assurance activity. I think there's a good working relationship there, and it's very collaborative. So whenever issues arise, the teams get together, and then there's also a group that brings in the sort of the other trusts as well, because the regional lab is providing services for women throughout Northern Ireland, so we have to bring in colposcopists and other from the other trusts to make sure that they're involved in that. So I think there are good relationships going forward. I think because of the nature of the activity that we're talking about, it's a hard thing to get right, actually, that relationship you have with a trust for whom you're undertaking quality assurance activity, because there needs to be a good relationship so that the full information is shared with you, and that there's transparency, and whenever something goes wrong, that Moira isn't afraid to ring me up and tell me. That you need that cooperative relationship, but you do also need to have enough sort of distance and, I suppose, a little bit of grit as well, to make sure that where there are issues that they're properly addressed. So it's actually a tricky enough balance to strike, actually, but I think that with proper use of robust data and proper use of objective measures, that's how you get around that.
Previously, what was the relationship like between the labs and the PHA?
So I think the NHS England report does make reference to some relationship issues. I can't comment on them any more than that. But it's difficult.
I'm fortunate enough to manage the new lab, notwithstanding the issues that we have at the minute with equipment. But my staff are really keen to learn from the past, to really embrace the new quality system, to ensure that we meet the high standard that our women deserve, and our families and our patients deserve. And again, our team with they're proud of what they want to do, and they want to reach that standard. So we're delighted to have a strong team, but we're also fortunate enough to have that quality that we can reach those standards and look at it day and daily, and over a period of time as well. So my team are proud to be there, and I say that we want to do better. We want to do better for the women of Northern Ireland.
As we move into the first sort of year's QA activity, coming up now that we're a year into service, we will bring quality assurance expertise from outside of Northern Ireland into that, because now we only have one lab. We need to get that external kind of eyes and critique brought in. So. Yeah.
Okay, I think that's a first step in rebuilding public trust in the screening process for women in Northern Ireland, and to make sure this doesn't happen again. So, thank you very much.
Thank you. Thank you.
Carpet.
Thank you.
Yep.
Thanks a million. Bye.
Thank you. Thank you.
Thank you.
Thank you, folks. I know we've been through quite a lot there. I thought it was important just to keep questions going, because I know members did want to speak quite a bit on this. Can I just ask if anybody has any comments about outcomes and about where we go now?
I was going to just say that we've had these presentations, or the representatives in, I think it was third time now, plus third or fourth, third. And to be quite honest, we're running out of questions to ask them, because they can't answer questions because they weren't there. It's not, I mean, we have plenty of questions to ask, just none that they can answer, if you know what I mean. So I don't really see where we go from here, other than, an inquiry that will actually compel people who were there at the time, answer the questions. Like, specifically, we do know, because the whistleblower has spoken to us all, much more of the issues in depth, but we can't answer them here. So I'm not really sure what we do as a committee, outside of waiting for this final report, or whatever it's called, from the minister to be written. But I can't see other than an inquiry where we will get any new information. We just have to be honest. We are not going to get any new information as a committee, because we do not have the powers that's needed. I don't know if that means that the committee, and if I need to make a proposal, I'm happy to make a proposal, supports a public inquiry, or if we don't need to go that far, but happy to hear others' views on it. But that's...
I was just actually going to say that. I think that as a committee we should make a view, if that is the collective view of the committee, that we, there are still questions to be answered, and that the only way of getting to the full bottom of this is a public inquiry with powers to compel witnesses, etc., etc. And perhaps we should write to the Minister to say that, notwithstanding the Professor Atherton report, that's where the committee feels that this should go. That would be my view. So I'm happy to, if that's a proposal, Nuala, I'm happy to support it.
So members, we've had a proposal, and obviously it's been seconded as well, but is everybody in agreement?
Yeah, I mean, look, notwithstanding again the point made about the individuals, they're coming in and doing what they can, but like I would challenge anybody to come up with any substantive piece of information that you're now aware of after the presentation and all of those questions than we knew at the start of it. We had the report, we could read it. It's really important and good to hear. But like when Diane talks about the Belfast Trust not having the equipment, the member staff in charge is going, well, that's not where we want to be. Well, I think we would be in a shocking position if that was where you wanted to be. You know, they're left in a position where, unfortunately for them, they've nothing other than the blindingly obvious to tell us. And I think that's because all roads point to the fact that we do need somebody that can delve much deeper to the people that were there at the time to ask them what happened, rather than people that are in post many years later coming in to tell us, well, that's not the way we would have done it. So I concur with what's been said and think we should pressurise the department into edging towards that public inquiry.
Anybody else? Alan, either of? No?
I'm not opposed to a public inquiry, and as I said, the public inquiry, there is this perception that the minister is down on it. I know from speaking to him that he's very open-minded to a public inquiry. He just wants to satisfy himself with all the information, and that's why he's commissioned this additional report, because it happened outside his term of office as well, and he's in the same position as we are, maybe not getting the answers that he needs because the people are not there that he can ask. So I think he's just been he's been prudent, but as I say, I'm certainly not opposed to a public inquiry at this stage.
So are members all in agreement that this committee takes a position that a public inquiry is necessary on this issue, a full public inquiry with powers to compel people to come forward, and that we should write to the minister outlining the committee's position and asking him to establish the inquiry?
And I would include in that the fact that we've exhausted all of the questions that we can ask of the people that are here in the current positions today, because they are given their limitations as to what they can tell us because they weren't in post at the time. So I think that gives a bit of credibility to why we're asking for a process that looks back the way to the people that we can't get access to at the minute.
Okay. Exhausted the questions that they can answer.
Yeah.
Definitely.
Yeah.
And there are definitely gaps in our understanding of what happened. I mean, I note that Steve Austin talked about this first came to our notice in October 2021. Sometimes it's been told to us that it was February 2022, and there's no rational reason for why they didn't take action on it until July 2022. So it's, it's understanding why did those things happen, what was the impact of those things, and how can we make sure that those things never happen again. And I don't think we get answers that actually do that. I mean these labs, including the Belfast lab. I mean, I understand that one woman's slide, who went on to develop cancer, her slide actually was found in Belfast. It was lost for a period of time. One of the reasons the Belfast Trust lost its accreditation was a lack of record keeping. I have that in letters from the minister. And there's lots of questions to ask, around this whole issue. So anyway, thank you.
No problem, thank you, Dan. Can I suggest then that the clerk drafts a letter to the minister outlining with the committee's position and asking him to bring forward an inquiry? Do we need committee approval of that letter, or are you happy for the chair or deputy chair to approve that letter with those?
Oh yeah,
with that wording?
That's just what we usually do.
Yeah.
Everybody's happy with that, yeah?
It's not the tablets of stone, it's fine. It's completely fine.
Over to you.
Okay, folks, anything else and comments want to be made on that item before we move on? Nope. Okay, folks, I know we are running behind. I'm going to move on to item number 8. Item number 8 is SR 2025-172, the Health and Social Care Exemptions from Charges, Payments and Remission of Charges, Amendment and Transitional Provision Regulations, Northern Ireland 2025. I refer members to the papers at tab 8, including the SL5 at page 266 and the SR at page 268 and an explanatory memorandum, page 276. And the correspondence with the department on page 10 of your tabled papers. And just to advise members that the committee has received a briefing from the department on the 18th of September and was content with the merits of the policy. The examiner of statutory rules has not yet reported on the technical aspects of the SR. Therefore, members will be agreeing the SR subject to the examiner's report. And just to also advise you that we do have an official on standby should members have any questions regarding this SR. Are members content with the SR as written? Yep. Okay. So just for the formality, I just have to ask that members formally agree that the Committee of Health has considered SR 2025-172, Health and Social Care, Exemptions from Charges, Payments and Remission of Charges, Amendment and Transitional Provision, Regulations Northern Ireland 2025, and, subject to the Examiner of Statutory Rules report, has no objection to the rule. All okay? Yeah.
And our thanks to the poor official that's been sitting outside waiting on us. I didn't realise that's what they were there for. We could probably have let them go a lot easier or sooner, but yeah.
Okay, we'll move on to item 9. So that's been agreed, Keith. Yeah, we'll move on to item 9, written brief from the Department on Workforce Policy. Refer members to papers at tab 9, page 281 of your main pack. Has anybody any questions or comments? No.
I do have
Very
some
quiet
questions,
room.
but I'm actually going to. I'll write them. I'll follow them up with Minister.
Okay. We okay to move on to item 10? Item 10 on your agenda is the committee inquiry, access to palliative care services, consideration of the report and committee motion. Refer members to tab 10, page 302 of the main pack, and the full report at page 19 of the tabled papers. I'll advise members that once the motion is tabled in the business office, the debate will be scheduled for Tuesday the 2nd of December. I'm just going to invite the clerk to make any comments about the report.
I'll be very short in this, Chair. Thanks. A number of members have made some recommendations for suggestions for changes. So you'll see in the papers is a copy of the track changes for the recommendations. We've moved some about as well to take into account some views. There was also some comments in relation to the body of the report, which we've automatically put in place. So we have. So really, it's just if members have any further changes, or are they content, because we're at the point now we do need to think about publishing and finalising.
Anybody has any further comments?
I need to come back to. But I mean, just so that I just go through it one more time. But it'll only take me too long.
We would need to do that. Let me say, I'll give you a wee bit more time.
Don't pressurise, Keith.
So well,
You're 7 o'clock tonight.
we were hoping to get it to business office tomorrow, but we could probably hold off to Monday.
Is that okay, Diane, as a hard deadline Monday?
I'm better with hard deadlines anyway.
No problem.
Can I just ask a question specifically on recommendation? Or just on the track changes, it will be recommendation 13 now. So we're removing. You're removing one. I'll wait until you get to it, because otherwise
it's
not be able to follow.
They're in the table paper or something?
No, it's in the pack. So recommendation.
What was recommendation 11 and what would be it's now recommendation 13, I think. It has 1 in black, 3 in red and 1 scored out.
Yes.
In red. We're removing that recommendation and putting a new one in.
I'm just.
Is it just I'm just.
I guess what's scored out is replaced by what's under it, and
So this new recommendation is you feel, Keith, that's it's just summarising it, that there's nothing.
Is that not just simplifying it?
Yeah. Is that okay?
We tried to. I think this is one of the points that you had raised, Diane.
I kind of read that and thought, the heck does that mean?
Yes, I think it was a case that originally there was maybe a bit more
That's probably why I think it's a new one, because the other one's so different.
That's the sort of thing I wanted to read.
We've narrowed it down to a focus on the transition.
Okay. Yeah.
So it is. We took into account that maybe that recommendation was a bit wordy. Is probably the.
That's why they look so different.
Yes.
Yeah. That's fine.
Okay, so we're not going to do the formal agreement today. Do we have to wait till next week, or can we do that by email then?
We would have to do that by email then. So it is. But what we can do is, if members are content, is agree the committee motion, because it needs to go to business office as soon as possible to get it on for consideration this Tuesday. So if members are content,
where is the motion? Is it?
Sorry, I have it here. I was waiting on advice from the business office. The wording is very straightforward. It's that this Assembly approves the report of the Committee for Health on its inquiry into access to palliative care services, and calls on the Minister of Health to implement the recommendations contained in the report.
Fair enough.
And if we could focus, I don't know, within the report, just acknowledge the funding issues, but that there are many recommendations contained within this that are not funding dependent. Yeah.
Happy with the wording?
Yeah.
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 Everybody else happy? Okay, we'll get that submitted to the business office then.
Absolutely. Then if members are content, following confirmation that you've had a read, I'll email members to ask that they're content that the report be published, and then I would need the majority of members just to come back to me on that.
Okay.
And then we can record that next week, that was done via correspondence.
Okay, so I think that's this item finished with.
Only took 60 versions of it.
We have no issue with how it's
He
currently done.
thought I was marking.
Just to let members know as well, the launch event is going to take place on the 2nd of December.
What time is that at?
12:45. Start at 12:45 with around 20 past 1.
That night. I have to give
Around
evidence of the inquiry in London.
And we hope to have the motion that day as well, and hopefully they'll be sort of in and around the same time, and we can tier the launching of the report. With, if we have the motion first, we will unembargo the report, so it can be discussed. Item number 11 then, correspondence. So to refer members to correspondence at the index of tab 11, page 319 of your main pack. And just to refer members to correspondence from the Belfast Trust regarding the response to the issue raised by the committee at tab 11 on page 328 of the main pack. Do any members have any comments on that?
Is that one now? Okay, sorry, Chair, can I come in on that? Yes, it's good to have the clarification. Just for the record, I didn't find it confusing. I actually knew it was wrong.
So we have 2 letters of apology, effectively, for misleading the community from Chris Hagan and from Alistair Campbell. Any other members want to comment on that?
I think it's good that they have outlined that they were mistaken in what they said. I think it's important. But hopefully when the review starts, we can actually hear about it, because there'll be an open framework. We haven't heard back from the responses to that. We also now have the Hillsborough law that could potentially come here. We have so many, the the Adult Protection Bill. We have so many different issues. We need to know where they all interlink with each other, and that's one of them.
Okay, folks, in terms of other items of correspondence, has anybody any comments to make on any other ones? No. Are members happy with the suggested actions within the indexes?
Oh, yes.
Yep. Okay, folks, I'm going to move on then to the draft forward work programme, tab 12, page 409 of your main pack. And just to highlight as well, in next week's meeting we'll have the Minister from 3 to 4:30, hopefully, and we have a few other events to highlight. There is the planned visit to the Mater Hospital then the subsequent week, and the planned visit to Enniskillen the next day. Keith, do you want to take us through that?
Thanks, Chair. Just very quickly, in relation to, there's a proposed visit to the Mater Hospital to look at the Psychiatric Assessment and Treatment Hub, which is a way of taking people with mental ill health out of emergency departments. And it's a pilot that they're running, and it seems to be very, very, very good. So they've asked us to go and visit that. At the same time, there's also an opportunity for members to get their flu vaccine, to encourage other health staff and others to get the flu vaccine. So if any members interested in attending and or getting their flu vaccine, they are more than welcome to get in touch with me to do so. And that's on Wednesday the 26th in the afternoon. The time will be, the invite will go out probably tomorrow to members.
Okay. Okay, and in terms of Wednesday the 27th then?
Thursday the 27th is the visit to SWA Hospital, and there'll be a full programme going out to members on Monday probably. So it begins with a breakfast meeting with a number of local businesses and two councils in the area who want to talk about services at the SWA Hospital. Then after that we've a short visit to the Cancer Focus Hub in Enniskillen.
Oh yes, that's very good.
And then on to the SWA Hospital for a tour of the hospital for lunch, and then the formal committee meeting in the afternoon. We are hopeful that there should be the opportunity to join remotely, but I can't confirm that at the minute. So I'm just waiting on confirmation of that.
Some of us have other committees on
Absolutely.
that morning, so it's not that we don't want to participate, it's just...
so I'll send out the full programme to members on Monday so that they can see it and they can let me know whether they're available, and we'll work with our broadcasting to see about the remote participation.
Could I just ask for maybe just forward looking through binoculars and stuff, maybe just to get a good confirmation of members, because you'd hate to have events on at 8:40 in the morning. I know certainly that would mean leaving home at about 5:30 for me to get down there for that time. So I mean, it's just not going to happen. But and there's others that have got committees on. But just I know sometimes whenever we organise events and we've got people in, and then there's one member of the committee or two members of the committee, it doesn't look good. But it might do well to get a straw poll of people as to whether they're going to be there. Because what time is the first event at?
9 start. So it is. Now I'll email members, and with a couple of options around that. So. When I email members, I can let members know what we can work out about
I know it's 2.5 hours from my home to get there. So I mean, I could be down to the best part of the way towards Cork at that time. It's just really, but I know that's a two-way road, so we'd like to get as much of it as we can get to.
So the members happy the clerk will email out options around that then?
Yeah, in the corner for me.
Members happy to with the briefings set out in forward work programme?
Yes, thank you.
Yeah. Move on to any other business. Have members any business they'd like to raise? No. Okay, folks, the date, time and place of next meeting. The next formal committee meeting is Thursday the 20th of November in room 29 at 2 p.m. and the meeting is now adjourned.